Great. Well, welcome everyone to the July meeting of the Oregon Health Policy Board. Happy to have you all here with us today. My name is Kirsten Isaacson. I'll be chairing this meeting. And before we get started, we're just going to review a couple housekeeping items so that we wanted to share with everyone. So the Zoom chat in today's meeting allows only meeting attendees to message the host and co-host and no other meeting participants. So any questions, thoughts, or comments that you have, they can be sent via Zoom chat to the meeting co-host or co-host. So if you have a supporting resource link to share with meeting participants regarding an agenda item being discussed, you could share that link with the meeting host or co-host, and then they can share it with the meeting attendees. All materials for today's meeting are available on the Oregon Health Policy Board website and hyperlinked in today's meeting agenda. And that link will appear in the chat. And also today we have some new and improved closed captioning feature and options. So Tara, I'll turn it over to you to share that and then do our roll call.
Sure thing. So we will have live captionings at this meeting and all of our meetings moving forward, and you can access those by clicking on the closed caption feature within Zoom. And I will also drop a link if you prefer to view the closed captions in a separate screen where you can edit the fonts and background colors to your choosing.
Thank you. Tara, do you want to take us into roll call?
Sure, absolutely happy to do that. Let's start with Kristen Isaacson,
I am here.
Dr. Hemmings,
Here.
great. Tony German,
Here.
great, good morning. Aaron Hines, okay, we'll come back and I'll check on Aaron. Bill Kramer,
Here.
great, good morning. Peter Starkey,
Here.
great. Hayden Rook Lee,
Here. Good morning.
good morning. Bess Jamie,
Good morning, I'm here.
good morning. And Eve Gray,
Here.
great. We have 9 members and all members are present.
Very exciting to have a full board, and we will do a proper introduction of our new board members momentarily. But before we do that, we're going to move to our tradition of starting the meeting with a reading of the health equity definition. Thank you so much for doing it this month, Peter. Take it away.
Pleasure. Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. Achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices.
Thank you. So just a quick review of today's agenda. We are going to do some welcomes, did a roll call, but we'll specifically allow our new health policy board members to introduce themselves and get to know them, followed by Claire with the Oregon Health Authority and OHPB updates, conversation, collaboration. We'll do an overview. We're going to hear an overview of the Governor's Advisory Group on Medicaid sustainability. And then hear an update from the Industry Advisory Committee related to the Affordability Committee. And then we will hear from the Affordability Committee themselves with their draft recommendation, then recommendations from the Primary Care Strategy Committee for legislative concepts as well. Public comment, and then we'll adjourn. So before we dive into all of that, I do want to remind all board members of our obligation to disclose any actual or potential conflicts of interest. So after reviewing today's agenda, if you have a financial interest, professional affiliation, or any other relationship that could be reasonably perceived as influencing your decisions or participation in today's discussions, let's take a moment now to share it for the record. And as a reminder, this can be an actual or potential conflict of interest, and this transparency really helps ensure the integrity of our work and maintain public trust. So would any members like to share an actual or potential conflict of interest at this time?
Yes, I do.
Go ahead, Dr. Hemmings.
I believe I'm not sure that we're going to be voting on this, but the Medicaid advisory report that we're going to discuss today includes a recommendation of a 4% rate reduction for behavioral health. If the governor were to move forward with that, it would impact me as a behavioral health provider. So I just wanted to make sure I put that out there as that any comments I make, that needs to be on the record.
Yes, great example. Hayden, Reclay?
Yeah, thanks and good morning. I raised this last time as part of my work as an assistant professor at Brown University School of Public Health. I'm grant funded on some work to assess the potential of instituting price regulation or price caps at the state level and increasing Medicaid reimbursement. That's funding through the Commonwealth Foundation that I just wanted to disclose.
Go ahead, Tony.
Yeah, we'll be just with the Primary Care Strategy Committee group. Obviously, some of those concepts are with reimbursement to general primary care, direct reimbursement, but certainly some topics that are pertinent to the broad scope.
Great. Thank you, board members. Appreciate your transparency and your contributions. So, next, I just want to share some good news. In June, the Senate appointed 2 new members of the Oregon Health Policy Board. So today, we welcome Bess Jamie and Eve Gray to their first OHPB meeting. Bess and Eve each bring experience and expertise that will really complement and strengthen our board as we provide policy oversight and guidance to the Oregon Health Authority. So I'd like to take a couple minutes now for Jamie and Eve to each introduce themselves to the board and the agency. Bess, let's start with you. Good morning.
Sure. Good morning. Hi, everyone. I'm Bess Jamie. I use she, her pronouns. And I am currently the director of the Essential Worker Healthcare Trust, which is housed under RISE Partnership. It's a trust that is a partnership between the SEIU Local 503 Union, long-term care employers, and the state. As we were talking about conflicts of interest, I should say we are funded through Medicaid supplemental payments through the state and federal government. I don't think it will touch on the conversation today around Medicaid sustainability because it's a separate pot of funds, but I do want to raise that potentially as a potential conflict. So we cover about 4,500 long-term care workers and their families, so about 7,000 covered lives. So I come to this work as a payer essentially, and really looking to support long-term care workers and those essential frontline workers in nursing homes and other settings caring for folks. Prior to this, I worked for Pacific Source CCO as their health equity and social determinants of health program manager. And right before that, I was the early learning hub director for Lane County. So, and I live and work in Eugene, and I'm excited to be part of this work. And it's near and dear to my heart as a direct service worker, as a doula and childbirth educator a million years ago. And then also as we look towards the future and how to sustain affordable access to healthcare for every Oregonian. Thanks.
Great. We're happy to have you, Bess. Eve, welcome.
Thank you. Good morning. I'm Eve Gray, she, her pronouns. I currently serve as the Director of Health and Human Services for Lane County. I I will say that we do run a primary care practice, a federally qualified health center. I oversee public health and behavioral health. So certainly a lot of the things that we will talk about in this group impact areas that I oversee. I did check with the Oregon Ethics Commission yesterday just to make sure, since we're a public entity, there's no statutory conflict of interest, and I don't hold any personal financial gain or loss associated with any decisions that are made in this group. But wanted to call it out so that folks know that those are areas I oversee. In addition to those areas, I oversee developmental disability services and our human services division, which includes our continuum of care, community action agency, veteran services program, and adult workforce services. My background, I'm a registered nurse by training. I've been in healthcare administration for about 15 years in inpatient and outpatient settings, worked in quality, patient safety, operational leadership in many different specialties. So bring quite a bit of that to this work as well. And I look forward to participating in this group. So thank you.
Thank you. We're happy to have you, Eve. I want to call out that Erin Hines has joined us as well, just since wasn't here during the roll call, that we really do have a full board here. So good morning, Erin.
Good morning.
So very first order of business this morning is to vote on the draft June OHPB meeting minutes. The draft meeting minutes are included in today's meeting packet as attachment number 1. Is there a motion to approve the draft OHPB meeting minutes from the June meeting?
So moved.
Second, this is Peter.
Thank you, Aaron. Thank you, Peter. Tara, do you want to do a roll call? Because I think we'll have some abstentions.
Sure, happy to do that. I'll start with Dr. Hemmings.
I was not at that meeting, so I will abstain.
Great, thank you. Tony German.
Aye.
Thank you. Kirsten Isaacson.
Aye.
Aaron Hines.
Aye.
Bill Kramer.
Aye.
Peter Starkey.
Aye.
Hayden Rick Lee.
Aye.
Eve Gray.
Abstain.
Thank you. And Beth Jamie.
I abstain.
All right, we have 3 abstentions, but the minutes pass. Thank you.
Okay. Thank you all. Okay. Our first update today is from Claire Pierce-Robel, Director of the Oregon Health Authority's Health Policy and Analytics Division. We really appreciate you being with us today, Claire. So begin when you are ready. I think you have some big news to share.
Thanks, Kristen, and good morning, everyone. This is Claire Pierce-Robel, Health Policy and Analytics Director, and I think that it has been an especially busy month here at OHA and across the healthcare landscape. I shared with the board last week that we will have a change in OHA leadership as our Director, Sadal Hathi, is stepping down. We will have time at the next board meeting to introduce our interim director. So just wanted to get that up front. The directors are transitioning this month, and we'll have more information to share in August. The other work has been really picking up around the new CMS rules on work requirements. So I'll go into that a little bit more. I think we mentioned at the last meeting that the release came too close to the June 2nd board meeting to provide those updates. And so I'll provide a little bit more detail this morning. Also wanted to provide updates on how PEB and OEB are managing the exit of the Providence Health Plan in 2027, and then announcement around the new superintendent hire and hospital compliance at the Oregon State Hospital, and then wrap up with updates on the Rural Health Transformation Program. So to start with the Medicaid changes, as I mentioned, the Federal Centers for Medicare and Medicaid Services provided more details about the work requirements and the Medicaid exemptions in early June. And at least upon that initial analysis of the 400-page interim final rule provided from CMS, the rules provided differed significantly from the guidance that OHA had been operating under for the past year. So specifically, CMS has directed states to assess whether, as part of the new requirements, states need to assess whether individuals' medical conditions significantly impair their ability to work. And the guidance stops short of detailing exactly how to make that determination. So that leaves states with significant ambiguity around, for instance, what evidence like medical records or clinician assessments, functional assessments counts for this purpose. Also leaves ambiguity around which specific conditions automatically suggest medical frailty or how severe a condition must be to qualify. So without additional specific guidance here, we anticipate that lack of detail will cause us to rework and reprogram a number of our IT systems and sets our implementation progress back. The CMS guidance also includes revised interpretations of medically frail that would make it more difficult for medically vulnerable individuals to qualify for exemptions. This also marks a significant shift away from the protections that Congress originally put in place. And so in response, Oregon has joined a multi-state lawsuit last week to challenge the change in the final rule, the interim final rule. So we understand there's a lot of uncertainty about how the new federal requirements will be implemented, and that people are justifiably eager to know more. So while we wait for more detailed guidance, we're continuing to do our work. We're strengthening our networks. We continue to train the OHP assisters as a really critical part of the network and connection to members to help them navigate through these changes. And we're building those connections so that we can share information quickly and clearly and confidently with members as soon as we have it. That piece just keeps being a little bit harder than we are hoping for. So our focus remains the same, that we're keeping eligible people covered so that everyone has a chance to live happy and healthy and thriving lives here in Oregon. So we'll be continuing to communicate that information in the coming months about the exemptions specifically and in advance of January 2027 as we know more. So switching gears, just another update on the recent announcements from Providence Health Systems that they will transition out of most insurance lines of business in 2027. So just following up that we've been continuing to work on preparing what that means for state employees, for marketplace enrollees who are covered through this insurer. As of the end of June, nothing changes for PEB Providence members right now. So state employees that have Providence Health Plan, that remains in place. Providence Health Plans remain contracted to cover PEB members to the end of 2026. And about 65% of PEB members are enrolled in plans offered by Providence. So this does have a large impact for next year. Luckily, the PEB board has selected MODA, Kaiser Permanente, and Capital RX to provide benefits in 2027. They continue under negotiations with the plans for the PEB 2027 benefits. And those negotiations include a focus on ensuring that there's a smooth transition with a coordination of members' care and a focus on robust provider networks. So that continues to be the goal of PEB throughout the process to make sure that those provider networks are in place for all employees, including those members that are transitioning away from the Providence Health Plan. Switching gears again to the Oregon State Hospital. So following a national recruitment effort, OHA has named Sean Murphy as the new superintendent of the state hospital. And Sean will begin his role next week on Monday, July 13th. Our interim superintendent, Jim Deagle, will remain on for 4 weeks in an advisory capacity to support that smooth transition. And luckily, Sean joins us with 3 decades of executive leadership experience across behavioral health, healthcare operations, public safety, and large-scale government and administration, which gives him a really strong alignment with our vision here at OHA for safe, compassionate, patient-centered care and organizational culture. And we're excited to have him join the team since he's such a collaborative and results-driven leader with proven experience in performance improvement and organizational change. So that really positions him well to support the Oregon State Hospital's complex mission of serving adults with severe mental illness while upholding the highest standards of safety, regulatory compliance, and clinical excellence. And also from the state hospital, as of June 8th, the state hospital is in compliance with the federal court's MINC injunction. The last time the hospital was in compliance was a little more than 2 years ago. So this is just a really positive development for OHA and the state hospital, but more importantly, it's good news for the people requiring admission to the hospital. So happy to share that news on both fronts with the board. And then finally, the last update I want to share with you all is that later today, OHA will award about $80 million in rural health transformation funds as part of the Catalyst Awards. This was the competitive funding opportunity that was released earlier this spring, and we're excited to continue to move this program forward. This rural health transformation program was created to support innovative rural healthcare improvement projects. And specifically in Oregon, the Catalyst Awards were intended to support projects that would be ready to launch within 2 weeks of receiving funding and address either maternal and child health, co-occurring behavioral health conditions, aging in place, or chronic disease. This is the first year of the Rural Health Transformation Program, and we had a short turnaround time to be able to obligate funds that CMS had granted to Oregon. So the Catalyst Awards, again, are focused on those ready to launch projects. But we know that the need to improve rural healthcare is clear because we saw more than 350 organizations submit proposals for Catalyst Awards when the expectation is we would only be able to support about 80 organizations. So we just see that the kind of the need and the innovation is out there. And as we've said from the beginning, unfortunately, this funding is really not enough to replace the lost federal funds that we anticipate coming from HR1 or to support the need. But the silver lining is that we will be able to support some of those innovative projects that will really make a difference. And that will be something that we'll be excited to continue to bring back to this group updates on throughout the year. So we will also be sharing more information about some of the additional immediate impact awards and be able to share that we're on track to allocate all of the funding that the federal government awarded Oregon for 2026 by the end of this federal fiscal year. So that was $197.3 million total. Some of the other awards that we have made so far include $21.7 million for the tribal initiative for all 9 federally recognized tribes in Oregon. We've also directed $35 million in direct funding for rural hospitals, $10 million to rural health clinics, $5 million in direct funding for local public health authorities. And we expect that the U.S. Centers for Medicare and Medicaid Services will continue to evaluate Oregon's progress against the Rural Health Transformation Program goals to determine how much funding our state could receive for 2027 and beyond. But this really sets us on track to ensure that we are able to obligate the funds and therefore be eligible for the maximum funding in future years. So with that, I will take a breath and happy to take any questions from the board, Kirsten.
Great. Thank you so much, Claire. Any board members have questions?
I have a question, Claire, just about the work requirements. I'm curious about if the rules talk about caring for somebody who's medically fragile or that has a disability as a factor in eligibility, the caregiving factors in.
Sure. So there are some specific exemptions around those that are, for instance, caring for or have a dependent of a certain age. There are other details that are kind of yet to be determined. And so I'm happy to take that one back specifically, Bess, and get you additional information on that.
Great, thanks.
Tony, go ahead.
Thanks so much, Claire. Breadth of things to cover there. I did want to zone in a little bit on the HR1 impacts. And one curiosity I have is with the volunteer, requirements, and mainly just thinking about it as a state, it kind of parallels with medical frailty and the documentation with that, and optimizing that and being efficient with kind of electronic reporting. I just wondered if you could share a bit more of the state's thinking on this, or what kind of, I know the challenge is spending money on new systems to update those, but have we been thinking as a state of tools that, a lot of people are restricted in their ability to work, but they could do some functions of this volunteer community engagement? And are there tools that we're looking at and leveraging so that we can document those efficiently?
Sure. So I alluded to this a little bit, that there are some of the exemptions that OHP members eligible, or those eligible for OHP, would be able to document either that they meet an exemption for medical frailty, or or meet the requirements that are related to the work or other engagement requirements that are introduced. So a big part of the IT build that is going on right now is around building those systems for either attestation or documentation of meeting those requirements. So that's a big component of what the new build is incorporating into our eligibility systems. For instance, for an individual that's volunteering and could meet their activity requirements that way, they could also combine that with working part-time. So there's part volunteer, part work. So all of that is going into the system to make it as hopefully as easy as possible to be able to document that those work or activity rules are being met. And to the extent possible, is relying on data that we already have within our state systems to be able to document that as well. So the idea is to, again, it is not going to be completely frictionless, but to try to reduce the friction as much as possible, especially for those instances where you have kind of, when we think about the journey map here, you have a more complex journey for someone that is, for instance, working part-time and going to school, or working primarily gig jobs, or have some other complicated way of kind of proving that they are meeting the requirements up to that level. So all of those are being various kind of types of customers, as it were, are being considered as the IT systems are being built.
Thanks, Clara. Just a quick follow-up. Do you know if the idea is that IT infrastructure will integrate with systems of the health system of like integrated or health electronic health records?
So a big part of our system will be looking at our claims data that we already have kind of in-house at the state. Those future, I will just say there's the kind of minimum viable product that we are building towards with the short time frame that we have to come into compliance with the federal law by January 1st of next year. And then there's what we can build for the future. And so I think there's lots of additional and more sophisticated ways that we can build that system in the future. Our first phase is really ensuring that we meet the minimum requirements of the law by January 1. So that will be really focused on, again, data that we already have and maintain as a part of administering the Medicaid program. And that includes claims, but not, for instance, access to clinical EHR data.
Thanks, Claire.
Ian, I see your hand. Go ahead.
Thank you so much for the update. And I too have a great interest in HR1, of course. My belief right now, so correct me if I'm wrong, is that because the first time someone is redetermined with the new requirements, they can self-attest to medical frailty. And we're still on a 2-year redetermination cycle until the fall. Probably providers won't have to start providing documentation until closer to 2028, would be my thought, but tell me if I'm wrong in that. And I do, I think we all probably have deep concerns about primary care access within our state. And if individuals do have to get into a provider in order to receive some form of documentation within a certain time frame, thinking about how are we staggering this to make sure that everyone can get in before, say, January 1 of 28, when a big rush may happen. And there will be some people who can still self-attest at that time. But what's our planning with providers and provider networks and trying to develop a plan to make sure that no one falls off Medicaid because they can't get into the doctor?
I can thank you for that, and certainly that is going to be a big part of the implementation of these new work requirements. I think the concern is that as I mentioned, ability to attest to medical frailty is not what we were expecting in the interim final rule, and that is part of what the state has joined a multi-state suit to challenge. So more to come on that front. Part of the communication that we are planning and have been continuing to push out both through our OHP assisters, as I mentioned, most of whom have been trained, and then as the OHA and OHP are communicating directly with members over the course of the next few months, we kind of think about this in phases. What is the action that members can take at any given time? Right now, for instance, really the update here is to make sure that folks are keeping their addresses up to date, are ensuring that they are getting the information about what needs to be changed or what needs to be updated, as there will be new requirements in the coming months. The first member communications will be going out directly in October, related to the January 1st requirements. And then from there, it really will depend on when a member is coming up for redetermination. So Eve, as you mentioned, the messaging to providers will once we have information about exactly what that will entail, will include information about when and how to assist OHP members with their documentation. And I think that is a good point, that there will be, at least for this first phase, kind of similar to public health unwinding, but much more intense because of the level of detail and new requirements that will be in place, that it needs to be kind of an all hands on deck effort there. But the communications that we are planning will be specific to members, will be specific to providers, and will be moving out through our regular networks and through CCOs as well. So thank you for the recommendation.
Great. Thank you. Claire, I had one question about that, Pat. Really appreciate hearing that update about that major change that will impact a lot of state employees. Also curious about, so PEB is now going to offer 2 plans next year. Is that correct?
In
And
addition
do
to
you,
a pharmacy.
right, okay. And do you happen to know how many final like qualifying applicants were vying to be a medical plan?
I believe when with Providence removing from the consideration, it was those final 2 candidates.
Great. Thank you. All right. Any last questions from board members? Claire. All right. Then appreciate it so much, Claire. We also appreciate you being a consistent presence with the board and representative of the agency and partner to OHPB. So thank you for being here today, and we look forward to hearing updates about the interim and more long-term director position. So thank you. And next up on the agenda, I see Bruce Goldberg coming on video and Christina, good morning. We are happy to have Christina Narayan and Bruce Goldberg with us this morning, both representatives of the Governor's Advisory Group on Medicaid Sustainability. And they're here to present the group's work over the past year. So thank you, Christina and Bruce, for your leadership and work with the Governor's Group. And you can begin whenever you're ready.
Good morning, everyone. This will be a test in my ability to share screen, so please bear with me. Can you see anything?
No, we don't.
Awesome.
And we have our slides on standby if your computer doesn't cooperate, but you can keep trying. Okay, I see something.
Success. It looks like it's coming.
How about,
There we go.
We're good.
is that large enough? That is the question.
It's good.
Cool. Well, thanks everyone. Good morning, and special thanks to the chair and vice chair for inviting us to spend some time with you this morning. I'm Christina Narayan. I am a senior advisor to the governor on health systems and health policy. With me is Dr. Goldberg, who will be a familiar face to many of you. Bruce, why don't you introduce yourself?
Hi, Bruce Goldberg. I've been serving over the last several months as a special projects advisor to the governor, really helping on this project about looking at how the state can hopefully mitigate the impacts of HR 1.
So we have a couple goals for today, but first, I think for folks who are tuning in, as well as board members, there are a few materials online. Certainly, the slide deck is available, but really want to point your attention to the final report. That report has far more context than we'll be able to cover in the time that we have today, and want to make sure folks are taking time over the next weeks and months to really dive in. There are significant appendices to that report, really providing context to the work, including two commissioned analyses that the advisory group produced in trying to fulfill the charge of the advisory group. What our goals are for today is first and foremost to bring you this information hot off the press. The governor received the report last night. We're pleased to be here this morning. There is a lot of interest for good reason in what happens next within the state because of our HR 1 impacts. There's a lot of education to be done around the HR 1 impacts. And so our first goal for today is really to provide some of the information that we've uncovered over the last 6, 7, 8 months of doing this work. We also want to present at a high level the options that the advisory group uh, put together and the advice that was given to the governor via the report. We hopefully will have some level of dialogue with board members if there's time, and definitely want to outline next steps. I think to do this, it's important to have some level of grounding. Um, I think many of you on the board know these first three figures. So when we talk about the Oregon Health Plan, we're talking about all of the programs that uh, create the Oregon Health Plan. We're talking about Healthier Oregon. We're talking about the Bridge program. We're talking about Medicaid Core. In total, over 1.4 million Oregonians, children, families, seniors, rely on the Oregon Health Plan for their health insurance. We know that over half of the children in the state receive care through the Oregon Health Plan. Our preliminary estimates, as Claire noted, due to direct federal policies around eligibility, are that at least 200,000 Oregonians are projected to lose health insurance, even as they are eligible for it under HR 1. And I want to share a new number for you. And this is really, I think, the impetus for the proactive work that the governor has started in seeking advice. And that's between the 27-29 biennia through 2031, we are projected to lose a total of $9.4 billion in state and federal funds going to our state and federal partnership that fuels the Oregon Health Plan, that fuels the Medicaid program, sorry. And what that means is really a system impact, it's a provider reimbursement impact, it's a coverage impact. And we believe that's by design. That's the intent of the federal policy. So before we go into kind of the intent and why the advisory group was created and what the governor is hoping to receive from the advisory group, I'd really like to walk us through a couple more grounding pieces of information. Many of you have seen this slide before. This is really the story of the Oregon Health Plan. What's not captured here, and I'm not going to spend too much time on the details. We certainly can return to it if there are questions. But this really talks about the trajectory of coverage expansion through the Oregon Health Plan in the state of Oregon. What is not pictured here but is worth noting is that overall enrollment in the commercial insurance market, that includes employer plans, individual market, group, et cetera, has really hovered around 2 million with a high in 2019 around 2.5, 2.4. Don't ask me about the Medicare Advantage numbers. I don't have those off the top of my head, but this is kind of our world. In bringing the advisory group's efforts to you, we really want to just reiterate that, the takeaway here is that Oregonians across the state rely on the Oregon Health Plan. They rely on Medicaid throughout the state. So when we talk about the system impacts and the individual impacts of federal policies, which for today's purposes will really be through numbers. We know that there are people impacts. We know that there are time impacts. We know that there's a lot of fear, but we will be talking in numbers today. When we're talking about those issues, we really want to ensure that the board and the public are aware that this is a statewide issue. And in some cases, this is a disproportionately rural concern. And this is from the OHA dashboard. I think visually this kind of tells that story. So why are we here? Claire gave a great overview of some of the policy changes around eligibility that will drive some of the projected coverage loss due to HR 1. It is certainly an administration goal, and the agencies are working well together to try to mitigate and automate and make as easy as possible the new red tape imposed by HR 1. I won't go into detail here since Claire really covered it, but the direct policy changes around eligibility are listed. As Claire mentioned, the state of Oregon is currently suing the federal government for their published rules that just came out last month for rules that need to be implemented on January 1. We believe that the published rules unlawfully narrow Congress's protections for medically frail Medicaid recipients and are working closely with the AG's office in that effort. The bulk of our discussion will really orient around some of the revenue policy changes in this longstanding state and federal partnership for financing the Medicaid program. The shortest, I think the most concise way to explain what these changes are is really just in two parts. First, the newly enacted federal policies shrink the tools available to states over time, and it prohibits access to those tools in the future. One way that occurs is really through provider taxes, which is a mechanism that nearly every state uses, some states more than Oregon, in order to help finance the state share of the Medicaid program. Also to make specific investments in quality of care, provider access issues, and other ways those tools have been used. Those are longstanding provisions that have been available to states. That rate will decline from a 6% threshold to 5.5% in 2028, down to 3.5 in fiscal year 2032. And states are no longer eligible or allowed to enact new provider assessments. The directed payments piece is a funny challenge in that it does affect our current intergovernmental transfer arrangement with OHSU. Ultimately, what directed payments are used for um, at least in the state of Oregon, are to drive targeted investments in state initiatives around quality. An example of that are the rural maternity payments that the governor included in her GRB and her governor's recommended budget that were narrowly approved by CMS, and we're pleased for that. But this policy in the future will make it more difficult for states to make targeted investments in areas of clear need, and that is a challenge. Because I haven't figured out how to animate my slide deck, I unfortunately can't make these arrows appear. So we're just going to look at all three of them at the same time. This slide is nauseating. It's okay. You can say that. It makes me feel that way every time I look at it. And so we're going to break this down again, just to ground us in what are we talking about and why are we here. So the blue arrow is really, if you look at that blue arrow, it's really a perverse statement, the savings estimate due to HR1. What this reflects is the estimated savings due to coverage loss. If you no longer insure people, you are saving some money. What is often unseen is the actual system impact of that. Non-reimbursable services, payments not going out for coverage that ultimately are distributed through value-based payments, other arrangements to providers in the health system. The best way to really look at this is to look at the 27-29 category. You see that the state general fund savings is about $412 million. So those are not payments going out anymore to cover people through their per member per month rate. The federal funds impact is $2.5 billion. That means that's the projected unreimbursable services and system extraction for 27-29 due to loss of coverage. And so when we say that everyone should care about Medicaid policy, it's because ultimately everyone is affected in some way because those costs are borne somewhere when individuals prolong care, they show up with more acute issues in emergency settings, and so on. So you can do the math, look at 29-31, same story. For the orange line, if you look at that middle row, that middle section, this is the true financing impacts. So when we were talking about provider taxes, state-directed payments, etc., these are the actual revenue constrictions that HR1 imposes on states. For Oregon, we're looking at some pretty significant numbers. And so in 27-29, we're looking at an $833 million general fund shortfall just due to the revenue impacts. You can see the federal funds impact is slightly, well, is the same. It grows in 29-31, which is essentially the story here based on that tapering of the rate. You may have a question about 25-27. There was an impact in 25-27 due to HR1 policies. The legislature did backfill some funds in general funds to kind of bridge us to 27-29. And so we're really not talking about 25-27 for our purposes. The green arrow shows the net impact. So if we assume a level of coverage loss and if we project the revenue impact, we're really talking about the net impact to the state. And as you can see for 27-29, the general fund impact is about 5% of the state's Medicaid program general fund share. That 5% hit grows to 10%. When you look at the total system impact, not just general fund, so if you're looking at general funds and federal funds from 27 to 2031, we're talking about a $9.41 billion hit to Oregon's healthcare system in state and federal funds. For those of you who don't stare at charts like these all day, I will just note that the other funds impact for 27-29 and 29-31 for the green column, you can think of other funds as really the administrative lever to make the state funds and the federal funds work. We don't really count that for our purposes here when we're talking about true system impact. So with that background, what are we trying to say here? We're trying to say that really HR1 will affect Oregon's healthcare system in two ways. projected loss in coverage due to federal policies, which result in fewer reimbursable services, an increase in the uninsured, destabilization of families, potentially systems. Second, direct limitations on federal funding and revenue policies. This will result in an immediate general fund shortfall for 27-29 that totals that $9.4 billion system impact by 2031. The net immediate general fund hole, if you will, that is projected for 27-29 is $421 million. So these federal changes, in thinking about this, the federal changes are really aimed at destabilizing Oregon's long-term commitment to keeping Oregonians insured. The intent of them is to compel states to take drastic action to balance the loss of federal funding. And so the primary question that the governor has asked this advisory group as the state confronts HR 1's impacts is, when federal policies are designed to kick people off of health insurance and to restrict our ability to pay for that, is there a way that Oregon can keep people insured, maintain a benefit that meets core member needs? And is there a softer, sustainable landing that we can propose or advise the governor on as she prepares her governor's recommended budget for 27-29? That is the core question that has really brought forward the advisory group on Medicaid sustainability. The focus of the advisory group, as you see on the slide here, is really the 27-29 biennium and beyond. The foundational principle that the governor has set forward in charging this work is to keep Oregonians insured. I want to share that when we talk about the advisory group's product, we're really talking about options. They're not recommendations because not everyone agreed. Consensus was not to be found. So these are really options that are advisory in nature. There may be strategies outside of this report. There may be things in the report that are of interest. But ultimately, this is the first step in getting feedback. And nothing really compels the governor to pursue these options. The governor just received the report last night, so certainly needs to take some time to be briefed by staff to get input from a variety of places as she reviews the work that has happened over the course of the last many months. I'll note that the report really focuses on the stakeholder advisory group. Bruce and I did have the opportunity to meet with several legislators on an ongoing bicameral bipartisan basis to make sure that the information and the data that we were uncovering was shared with members of the legislature. Any feedback or advice that they had for us is also advisory to the governor in nature, and it's not really captured in the report. That will be captured via a series of briefings as we do our work to download the efforts of the past many months. So with that, I'm going to turn the deck over to Bruce to really talk about the values and principles that set a parameter for the work, how the advisory group did its work, ultimately some of the key questions the advisory group asked, and the options that were produced in response to those questions.
Thanks, Christina. Let me just preface going through the principles and how the group worked with just giving some larger context and linking this back to that budget chart. In essence, the group was charged with looking at how we can, quote unquote, fill that $421 million general fund budget hole. And that's not easy. Looking at a budget hole of that size, given the economic situation that the state is in, there aren't a lot of good options. You're really looking at do you reduce benefits to OHP recipients? Do you reduce payments to OHP providers? Do you decrease the number of people on the health plan? Do you look at efficiencies? There's a limited number of options, most of them not very good ones. And so the group decided, how do we come up with some guiding principles? One was, investing in Oregonians and supporting Oregonians' ability to thrive. I think key was the next one, which was to the greatest extent uh, assuring that we don't cut people off of coverage. So protecting healthcare coverage, not reducing enrollment. Aspiring to maintain an adequate network of healthcare providers, that's key. Having coverage doesn't do you much good if you can't access care. And if we cut rates to the point that we don't have participating providers in a Medicaid program, then we're not providing access. Need to be certain that things are reviewed through an equity lens and to avoid deepening inequities and prioritize consumer affordability and sharing and coordinating a commitment to Medicaid programs across the healthcare sector. Next slide was, to the extent possible, we tried to use data-driven insights to leverage the strengths of the CCO model and to try and avoid anecdote and really work with data to identify and address underlying controllable factors that drive cost trends. We really spend a lot of time looking at what were the cost drivers. We're seeing healthcare costs increase not just in Medicaid, but in the commercial sector, and looking at what we could do to address underlying cost trends, and you'll see that. Clearly, a piece of this is also minimizing administrative burden, making it easier for providers to deliver care and maximizing their work time to be able to deliver care. Preserving quality of care and prioritizing prevention-based interventions obviously was key. And lastly, understanding system-wide impacts of recommendations and ensuring that recommendations were broad-based and were felt across the marketplace. We had a really bright group of individuals, really committed. We met every 2 weeks, just about, except for holidays, for several hours. So a significant commitment. We had, representatives from CCOs, from hospitals and health systems, from unions, from FQHCs, from dental plans, the Oregon Latino Health Coalition, the Oregon Medical Association. Right off the bat, this wasn't a representative group. There's a lot of representation that isn't here. That's why the next step is going to be so important, which is to get additional input from individuals and groups across the state about, what they see as other ways to reduce that $421 million budget hole. I'm going to keep coming back to that number because that was the number the group kept coming back to. Next slide. In what was the scope? Well, the scope was really the Medicaid budget within the Oregon Health Authority. That was the focus, that was the charge to the group. How do we deal with that $421 million budget hole within the Medicaid budget within the Oregon Health Authority? What that meant was budgets outside of the health authority, long-term care and long-term services and supports administered by the Oregon Department of Human Services was not a part of this work group. Next slide. Okay, the group actually approached this very methodically. One, as just indicated, discuss the guiding principles to anchor the work and really saying that, we need to preserve coverage levels and protect access. Those were two key issues that drove the group. We then really looked at a comprehensive review of the Medicaid landscape, looking at trends over the last 10 years, what's happened to enrollment, to costs, financing, spending patterns, utilization, what were the key cost drivers. We spent several meetings really looking at cost access, financing of Medicaid enrollment over the last decade. And then we started to develop a series of budget options, which were analyzed by OHA and actuarial consultants. Next slide. I think as you can imagine, participants brought a lot of different lenses to the discussion, particularly including concerns about access to care, provider sustainability, administrative feasibility, long-term stability of the Medicaid program. That was something that the group really focused on. The options that the group identified really spanned, there wasn't one fix to this. As you'll see, multiple options that span what can we do administratively, what can we do around benefits, operational financing issues, cost issues, etc. The options do not include any reduction in enrollment, so that's really key. And the options really were short-term options for 27, 29 that will roll up as longer-term strategies into the future. The report contains 46 options. Those options actually add up to a lot more than 421 million. Some of them are mutually exclusive. If you do one, as you go through the options in the report, it's really noted where if you make one choice, it precludes a second choice. The options represent strategies that are informed by data that were reviewed by the advisory group. Not everyone in the group endorsed all these options. As Christina mentioned, we didn't work on a consensus model. We worked on let's just get all the good ideas out there. This was really difficult, and no one really wants to reduce things in the Oregon Health Plan to our most vulnerable citizens. And so, we couldn't operate on a way where everyone got to say no, we would come up with nothing. So the issue was, how do we get all the ideas out on the table and look at those? The governor is not obligated to pursue any option. She's going to be briefed and we'll want to get additional input, have additional discussion, hear from a variety of different constituencies. And then ultimately, the governor and the legislature are going to have very difficult choices to make. We've had 10 years of, continuing to add to our budgets. We now are facing some significant budget impacts due to HR 1. $421 million is a lot of money. The options, those 46 options really go into six categories, and I'll walk through those. One is kind of CCO structure. Another is clinical efficiency and utilization management. A third is provider rates. A fourth is pharmacy, a big cost driver. A fifth is benefits. And a sixth is looking at across the board budget reductions. Let me go through each of those in a little bit more detail. Actually, to go to the next one, Christina. So, when looking at CCO structure, the key question was what savings can be achieved by streamlining the numbers of CCOs in the overall administration of the physical health plan? Is there some efficiencies to operate the dental health benefit a little differently? There were a number of options that were identified, looking one at how can we reduce just the administrative costs in the current system, 1 to 3%. Can we streamline the number of CCOs? What would that look like? Are there ways to change the way we do DCO contracting as a fee-for-service carve-out or having a single DCO administrator? Each of these are costed out and are described, in the plan. Next slide. Looking at clinical efficiency, what does the data show us about those costs that are of high utilization and low value? What kind of care do we deliver that's low value, high cost, high utilization? And how do we start to move that care to high value, lower cost care? Are there ways we can do that? Are there ways we compare to other states? Are there places that, quite frankly, we overutilize healthcare and that we can reduce that utilization without providing harm? I think for those of us in healthcare, many of us know that not more, more care isn't always the best care. And sometimes we do overutilize care. We had actuaries look at places where we overutilized care, compared ourselves to other states, and looked at how we can address those. There's a real call for the Health Evidence Review Commission to identify some of those clinical efficiencies that have been identified by the actuaries, looking at things like how can we institute clinical guidelines, et cetera. Health Share of Oregon has put together a model to care for high acuity behavioral um, health issues. How can we expand on that? That's a way that actually we can improve quality and lower costs. They've got a model that is able to identify high utilizing uh, individuals with serious behavioral health issues, and that providing a variety of services and care management can actually improve quality and lower cost. How can we expand that? Are there ways we can change the non-emergent medical transport contracting? Um, as we identify CCO cap rates, we hold them to quote some clinical efficiency standards. What would it look like if we increase those clinical efficiency standards? So there's just a whole host of options around clinical efficiencies that you'll see in the report. Next slide. Normalizing provider rates. We tried to look at, do we have any outlier rates and how do they compare to rates across the system? And looking at how can we normalize those rates where are there places where rates exceed Medicare and commercial payment? Next slide. Pharmacy was identified as a key cost driver. It's a big cost driver of costs within the Oregon Health Plan. How can we, what can we learn from other states? We actually had a report that's an appendix in the overall report where we had some great folks from the Smart D program interview about 10, 12 other states, looking at what they're doing to get better value for their pharmaceutical spend. Are there some other ways we can reduce costs? There are some ways we can be more efficient in our pharmaceutical spend. We looked at some rules about provider prevails. We have some work around having a single preferred drug list, and also around both having a single preferred drug list and a single pharmacy benefits manager. These things get technical, but they're outlined in the plan. And then we come to the last slide. Well, actually, second to last slide. My apologies. We looked at optional benefits. Medicaid nationally, to be a federal Medicaid program, you have to provide some mandatory services like hospital care and doctor care, labs and x-rays, but there are a variety of optional services. I think surprising to many people is you can have a Medicaid plan and not have pharmacy services. There's a whole host of optional benefits. And the question was, how does Oregon's benefit package compare to other states? And are there ways we can rationalize in some way our Medicaid benefit? So we looked at that, and we looked at two things. We looked at the list, the general list of optional benefits, and we looked at how those could be reduced, cut in half, for instance, and what it would look like if some of those benefits were totally eliminated. So there were some choices to be able to have the HERC identify ways we could not totally eliminate a benefit, but reduce something, and also then how it would what it would look like to reduce benefits totally. The group was pretty clear about wanting to protect optional benefits by reviewing limits and to shy away from eliminating benefits. Now we can get to the last slide. The last issue was, as you can imagine, we put together, over 40 options. To administer that is really difficult. And so the key question was, could an across-the-board reduction be more predictable for providers than multiple interventions and system changes? So we looked at what it would look like having across the board OHA Medicaid budget reductions that spanned from 0.5 to 4%, and a lot of discussion about the pros and cons of that. I think what the group really came to was a priority for looking at some key system-wide cost reduction issues, because that would help us out into the next biennium and would make much more sense from a sustainability issue. So let me turn it back to Christina for, I believe, what is one more. Oh, no, hang on. Let me go through a few more, and then I'll hand it back to Christina. So some main themes and takeaways. So one was a preference for looking at administrative efficiencies before rate or benefit cuts. That just makes sense. Including how can we get a better value in the state's pharmaceutical purchasing. So let's take a look at administrative and pharmaceutical reductions before we go elsewhere. There was clearly a preference for clinical review of optional benefits and preserving them, but doing a good review from the HERC and being able to look at places where perhaps we can reduce optional benefits without doing harm. There was a preference for maintaining adult dental services. Adult dental is the highest cost optional benefit, and the group was pretty clear about a preference for maintaining adult dental services as an important part of keeping people well, as you can imagine. The budget gap grows significantly in 2931, and there's a need to focus on ideas that will assure long-term sustainability. That was what I mentioned. How can we start to do some things now that will help us be sustainable in the future? A caution that some of the quote utilization reductions can be rate cuts if they aren't incentivized appropriately to achieve behavior change amongst providers and members. Next slide. And just one last comment before getting to the next steps, and I'll turn it over to Christina. There is also a section of the report that looks at longer term sustainability. And are there some things that we can do to really look at the Medicaid program with a sustainable arm? And you can read through that section. It basically talks about a core benefit for Medicaid, administrative simplification, reducing some of the complexity in our behavioral health system, better defining CCO outcomes and coordinating around long-term care services. So you can take a look through those. We really don't have the time to go through all of those now, but they're key pieces. And with that, now I can turn things over to Christina for next steps, and then we'll take some questions.
Yeah, thanks, Bruce. One of the, I think, additional takeaways, and Bruce, I've heard you say this many times in facilitating this advisory group, and so maybe I'll editorialize now, is just in an environment with fewer resources, greater focus is needed. That's clarity and prioritization for providers in terms of expectations and serving the Medicaid and Medicaid enrollees, for CCOs in having the incredible responsibility of being the steward of our program, the state in setting and aligning expectations and incentives to achieve that focus. And I think that will come across in the report quite well. So in terms of next steps, I feel I can say with some clarity here that the governor is pretty dang frustrated to be in this position of responding to federal reductions, particularly at this scale, both for the people impacts of these policies, but also um, the position it puts the states in an environment of many needs. Certainly, responding to federal policies aimed at reducing healthcare coverage is not where she wants to be. The goal in establishing this advisory group is pretty straightforward. The governor is looking for options from a group of um, really seasoned individuals to help her understand what is available to her as she develops her recommended budget that can help her achieve her primary goal of keeping children and families insured as the state tackles this HR1 challenge. In doing that, I want to make sure that we're clear on next steps, which is that the advisory group was, I think, an exercise in foresight to get an accelerated view and preview of some of these challenges and to get a group of esteemed individuals together to give her early and preliminary advice. And that this is the end of that process. And we're presenting on the end of that process. What it means is that the budget process is just beginning. And so in that budget development process, the governor is going to need to look at the enterprise environment of needs and opportunities and administration goals of how best to support the state. Keeping Oregonians insured is going to be one of those foundational principles that drive her recommended budget. And there are other goals that we have. These numbers will change. So one example of the most immediate data input we'll have is the September caseload forecast. We'll get a sense of our projected enrollment versus actuals. Certainly, there are other forecasts that will drive and inform the budget and our overall target. The governor just received the report last night. We have a lot of work to do between Bruce and I in making sure that she has the full context of our discussions. And she's going to want to hear from other folks. As Bruce mentioned, there are a lot of options in this report. There may be options not in this report that she is interested in learning more about. Of the options in the report, some of these will require operationalizing if they are pursued. This is going to be a long process to understand, one, are our budget projections even true based on the operational considerations? Three, two, is it administratively feasible to implement? And so I really just want to caveat that these are well vet, but first blush options really around the goal of trying to minimize the impacts of HR1 and meet her goal of keeping folks insured. The governor's recommended budget is really the first step for a blueprint of a budget, a balanced budget for the state. She is statutorily required to publish that on December 1st. Decisions need to be made a little bit earlier. You can go look at the statute for that date. I think it's mid-November. Please don't quote me on that. But 12/1 is essentially what we look at in terms of the governor's recommended budget. Our goal in convening a small group of legislators was really rooted in understanding that this is a significant budget challenge with real people impacts, and we wanted to make sure as much as possible that we were keeping our legislative partners informed with the data and the information that we were reviewing, as well as getting their feedback to the governor. The legislature ultimately will be the entity that adopts an approved budget for the biennium. And as you all know, that goes well into late spring, early summer. And so really just want to caveat that this is the start of the process. These are not decisions made. This is the first chance at some formal options being presented to the governor, rooted in her goal of keeping folks insured. And with that, I will just, amplify that the report is posted online. It's a short report, maybe 30 or so pages. It's about 170 pages in total due to appendices. There's significant information on the background of our financing structures, enrollment in OHP over the years, a more in-depth review of the HR1 impacts. And the two specific analyses that Bruce mentioned that were commissioned for the advisory group are also part of that appendices. And Kirsten, I'm not sure it's safe for me to try to manage Zoom any longer, so I'm going to stop sharing screen.
Sounds good. Well, deeply appreciate this insight into the work that has been done and the process that is kicking off. Um, are there any questions from board members or our guests? You go ahead.
I would just say that I appreciate all the work that went into this. It seems like a lot of thought, and certainly appreciate the committee's focus on reducing administrative costs prior to provider rates and benefits for individuals, the focus on maintaining coverage for as many individuals as possible. I think globally, those are the right things to focus on. There's maybe a nuance in addition to unnecessary care around individuals who end up in very high cost care because they did not access the lower cost care. And if there's a way for us to get some more data on that, to have a focus on how we do outreach to those at-risk members to hopefully, get them to take their blood thinners so they don't end up with the bypass surgery or the intensive care stay for a pulmonary embolus or something like that. That I think there may be some additional nuance and opportunity there, but just really appreciate. We'll have lots of time to talk about the specific recommendations. I won't go into that here, but just expressing appreciation.
Thanks, Eve.
I would just respond, Eve, that no, I think you're absolutely right. And a focus of the group was to really focus on, what, I would put in quotations was called preventive care. How can we make certain we keep people healthier and how do we prevent them from, higher cost care out in the future? One of the issues that I mentioned, that health share model around behavioral health really focuses on that. And there was some discussions about, working with CCOs to do exactly what you were mentioning. So, I think that's some of the longer term issues we need to look at.
Okay. Hayden.
Yeah, thanks so much, Bruce and Christina and the whole group for this report. Two quick questions. One was, is there a general sense of which interventions, if we're thinking about magnitude, would generate the greatest amount of savings? Any sense of direction that the group got, again, on this magnitude question? And then second, I know math gets wonky here quickly when we're talking about state-directed payments and matching funding, but I'm wondering if the 421, I think it was there consideration in terms of when you're thinking about various places to make cuts, was there consideration of the implications on that for matching funding, understanding that spending in different categories in Medicaid draws down like varying degrees of matching funds, which would obviously factor into this calculation of basically how we can most efficiently go about this? Or, perhaps there just wasn't time to get into that level of details in the 421, I think. The places we looked to cut were looked at in equal measure.
Yeah, Hayden, let me take the latter part and then have Bruce elaborate on both. I think for folks who aren't tracking quite at the detail level that Hayden is, let me first simplify the question in terms of Medicaid is a state and federal partnership. We get match services for our state general fund contribution. That's how it's always worked. There are some changes to that. On the first end, when we look at the HR1 policies that affect our general fund whole, going back to that chart, you really see that the state general fund contribution is pretty commensurate with the federal funds. So if you look at 833 in terms of the total state fund impact of those policies, $833 million loss in state funds. The federal funds loss is equal. I don't have it in front of me. It's around 833 million in federal funds as well. In terms of how the work group approached its work, this is a little bit about covering a lot of ground very quickly, spending a lot of time in that process, but also having some limitations. For the purpose of how we do our state budget, we often are focused on the state general funds portion. And so what you'll see in the report is while we did look at federal funds impacts generally, it is presented in terms of state funds. The question you're asking is, will some of these options, if they are developed, have a disproportionate federal funds effect? And should that be a consideration in their choice? It's a good asterisk for us to definitely take back.
Yeah, and I would just put a finer point on that. We looked at some of that about the different, for folks who really want to get wonky about all the different match rates and populations and way that Medicaid is funded. So those are, considerations one can have. But, Medicaid has those different match rates based on populations, not based on procedures. So I think it's important to kind of keep that in mind. As to the first question, Hayden, yeah, there's actually an appendix in the report that you can look at where the actuaries looked at the magnitude of each of those kinds of interventions. Where are we high utilizing? What's the magnitude of that? And actually cost some of that out. So that information is there. The the flip side of that is, as you'll see, unfortunately, there isn't sort of the one or two things you can do to save $421 million. It's actually a lot of small things that one needs to do, but that order of magnitude is there. And I think those were some of the things that the group did consider, that what is the magnitude of the change, and was the change worth the administrative capacity to get, or do we need to spend $1 million to get $1 million reduction, et cetera?
Bill and then Tony.
First, thanks, Bruce and Christina, for the presentation and for your leadership on this work. And thanks to the entire advisory committee for the work that it did. This is very challenging, difficult work and involves a lot of complex analysis and difficult trade-offs. I had a question about one of the categories of the options around clinical efficiency and utilization management. Understanding that there are some opportunities there where there may be low value or even unnecessary care that's being provided and paid for currently. A question, though, about how to achieve those. And there's a reference to incentives in one of the other slides. I know there's not an easy answer to this, but could you give a flavor of the advisory committee's discussion of how these clinical efficiency and utilization management initiatives might be achieved?
NICU might be a good example.
Yeah. So Bill, great question. And you and I have worked on this for, decades. And I think this is one of the, key questions of healthcare is, how do we make certain we get the best care, the right care to people, and what's the best way to do that? And I would say this, one, the group spent a lot of time talking about this. And I would summarize this as a sense that no one's figured this out yet, that there's concern that, as I indicated on one of the slides, that just having some sort of talking about some of these efficiencies really just comes down to a rate reduction because there isn't the infrastructure put in place to actually get at that sort of behavior change, et cetera. So I would guess I would summarize it by saying a lot of discussion, a sense that this is something we need to do, a focus on that we have a way here in Oregon that makes a lot of sense, which is the HERC, where we have a public process to really look at how we can look at reducing high cost, less efficient care. How can we establish some of the guidelines and some of the payment ways? We've been doing that for years. And I think a sense that we need to reinvest in some of that work and a preference for doing that. But I think understanding, as you know, that it's difficult. No one's figured this out yet. It always sounds great to just we're going to provide some incentive or disincentive, only to find out that there's issues that happen that are unforeseen. I guess I would just leave it there.
I might elaborate just to give a tangible example in that, there are really three things happening when we talk about this. And to Hayden's question of where can you get the most bang for your buck? Well, it's only as good as the design, should it be pursued, which I think is the point Bruce is making here. So there are three things that are happening, right? So when we develop the capitation rate, which is the money that CCOs get based on projected utilization and the acuity of their population, in simplest terms, we infer based on that data a level of efficiency. And so there's a lever in terms of the funding. Now, achieving that versus just squeezing the money they get based on how we want them to perform is where it gets more complicated. And so the example that I think Bruce and the team of consultants did well to bring to the fore, and this is in Appendix 3, is really where are we having these avoidable visits or where are we an outlier? And so by looking at Washington and Idaho, we have the example of NICU visits. There are some unavoidable reasons for NICU visits. And then we also know that there are different perinatal care coordination and interventions that can reduce that. So how can the state bend our incentives, bend our metrics, bend our expectations in order to have everyone rowing in the same direction towards that opportunity of achieving the efficiency, not just reducing the rate for CCOs and telling them to go figure it out? I think that's where the operationalizing of some of the options, should they be pursued, gets a little bit complicated in terms of actually achieving the savings.
Let me make it even more complicated and actually throw it back to the board, which is understanding that Medicaid doesn't operate as an island. It's actually part of a larger healthcare system. And so, yeah, how do you drive care? But you can't look to Medicaid, the lowest payer and the least incentivizer of the right care in a larger system. How do you drive that system change? Because those cost drivers in Medicaid are exactly the same as the cost drivers elsewhere in our healthcare system. So you can't look at Medicaid in isolation. And we need to look at that. And I think that's what makes it so challenging is if we're going to reduce, as a state are very fortunate in that most of our providers provide care in Medicaid as well as elsewhere. And as a result, how do we look across the system to drive that sort of change? That's really important.
Great, thanks, Bruce. And Christine, I think you're making an important point that Medicaid is part of a much larger ecosystem, and the affordability crisis affects all segments. And so some of these initiatives or options that have been put forward, I think, are very relevant for the broader task of improving affordability for everyone in the state. So thanks again for your leadership on this.
Great. We are running short of time, so I'm going to turn it to Tony and then I'll do one last comment.
Great. Great deal of gratitude for impossible choices. Thanks for your commitment to being careful and thoughtful to this. Uh, just with regard to the recognition of the complexity of administration in our system. So I think this is just an opportune time for us to look at that and create that simplicity. I do see some of these options. It's just the observation that they have the trade-off to potentially actually create more administrative complexity. I think just a careful attention to that to limit that, and with the principles being that we don't want to drive providers or the health system from being able to provide that care. That's just one comment. The question too, in aggregate of all these choices, looking in the next biennium, it seems to be close to meeting the mark, but in that 29 to 31, it seems to me that the interventions here will not meet the mark. Is that true?
Yes, they won't roll up to be the 833 or whatever that number is. It gets worse. And what we do in 27, 29 will make it better, but it won't alleviate that. And the other thing I would say, Tony, is look at the sustainability section at the end about administrative burden, because I think it addresses a lot of what you're talking about. Things like, prior authorization and the administrative burden of that versus being able to have clinicians have time to deliver care and being able to address some of that.
Thanks, Bruce. Thanks, Christina.
Yeah, and I might just add, Kirsten, if I may, the imminence of the HR1 impacts for 27, 29, we're talking about policy changes we just got guidance for in June that have to be implemented in January, as Claire mentioned. The effect of some of these budget challenges due to the payment changes from HR1 are in 27, 29. I think our goal is to stabilize and have a sustainable program so that we can have a longer term discussion. I must just reiterate that this is going to have to be an iterative conversation. And that is in tension with providers and people who want predictability and sustainability. But those numbers in 29, 31, they are large. I can't imagine this being the first and only discussion that we have for 27, 29.
Yeah, absolutely. Dr. Hemmings, I see your hand up. Feel
Yeah,
free.
I'm going to try to make this really quick. I'm sorry I wasn't able to get my hand raised earlier. I always get concerned around advisory committees because I think that they're very powerful, right? And so I had a lot of questions, but I'm just going to focus on just saying what Dr. German said about administrative burden, that I was just wanted the committee also recognized in the report that was given to the governor that one of the impacts of additional administrative burden also impacts access to care, right? I think we could agree with that. The other thing was I wanted to find out whether or not if lives lost was calculated as part of the impact of some of these recommendations. So, for example, when we look at dentistry, at dental care, um, any changes in terms of reduction or impact to access to care, will definitely impact lives, actual lives lost. Um, Similar to mental health. And I was just wondering if there was data collected around that. Specifically, if you look at lives saved as a result of when the state started covering adult dentistry, the expansion in behavioral health, and what the impact would be to, because, we're looking at money, right? Cost. But also, cost also should include lives that may potentially be lost as a result of changes. And I think that should be included in whatever recommendations is given to the governor.
Yeah, Dr. Hemmings, thank you for those two thoughts. I think first, you have a partner in our administration in identifying ways to ensure that providers are spending the best use of their time in service to patients. And so I think the administrative burden question is something we very much are interested in and have worked with several agencies now on, and certainly there's more work to do there. As it relates to lives lost, I think in that specific term, I don't think that's reflected in our work. What I can share is that a lot of this work, unfortunately, but by nature of the work, is translated in budget figures. We had a lot of discussion in the advisory group about the impacts, both positive, unintended, or negative, of some of these options as they are presented. In the table there that does outline the 46 options, there are three categories of potential impacts that certainly are not comprehensive, but try to capture impacts to members, impacts to CCOs, impacts on the full delivery system. So want you to know that this was a discussion around people impacts, but I think in terms of that actual quantification of lives, no, I don't think you'll see that directly reflected in the report.
Thank you. I didn't. That's why I brought it up.
Christina and Bruce, really appreciate you being here with us today. Before we move on to our next agenda item, I just want to zoom out with a brief comment that, like, I don't think it can be understated how much immense federal pressure Oregon is under to cut healthcare for Oregonians. So really appreciated that you had that grounding portion of your presentation. Our goal as a state has always been to improve coverage, access, and quality. And while the federal government is going in the opposite direction, I do want to call out and thank Governor Kotek for standing up for Oregon's values and to have those values so clearly articulated and outlined in this presentation and held center in the work going forward. Thank you for being here. We look forward to hearing more and this process being underway. Okay, moving on to our next agenda item. Eve Gray, our new OHPB member, also happens to be chair of the Industry Advisory Committee, and so is going to provide us with a committee update. Eve, we welcome you.
Thank you.
With your many hats.
Yes, absolutely. So I will be brief on this. We are focused, as I think you are aware, on administrative burden for providers as part of an overall cost reduction strategy in the healthcare system. That we had started to hone in on a couple of pieces. One is quality metrics and trying to figure out how we take all of the different quality metrics from all of the different payers and streamline this a little bit more so that providers can have a sense of focus and can put fewer resources into figuring out how to calculate the numerator and denominator on everyone's quality measures. So we did get a presentation from the OHA at our last meeting. They talked about a lot of the work that's been done on this already, and then they brought forward some examples of models from other states. Didn't have a lot of detail on that, but did point out that other states have passed legislation that rolls commercial plans into the requirements that are governing Medicaid systems so that you get consistency across the commercial and Medicaid systems. We did ask the OHA to go back and gather more information on those other state models and how they work in order to potentially put together a proposal for the state of Oregon that would do something similar in streamlining quality metrics, because that seemed to be one of the major problems related to past initiatives, is that commercial plans were excluded. The other piece was credentialing, centralized credentialing. I think the group loved the fact that this is happening for behavioral health and felt like, gosh, it should happen for everyone. The OHA came and again presented on past work that's been done on this, some of the complexity and why they abandoned that work in the past. So I think at this point, we're recommending that the behavioral health piece just continue to move forward. We don't bring forward an additional legislative concept for next session on centralized credentialing to expand that until we see how the behavioral health rollout works. And there is also more conversation about the cost growth target and the administrative burden in terms of responding to the Oregon Health Authority on that. That's another high priority topic for the group. I think trying to make sure that we hone in on administrative burden associated with that and not eliminating the cost growth target, because that could have the opposite effect of what we're actually there to achieve. And then we listed out a number of other potential options that seemed like longer term goals and maybe not ripe for this next session. So once we get something on the quality metrics piece, I think we're going to be moving more into some of those longer term options, and we'll continue reporting back to you.
Wonderful. Thank you so much, Eve. Okay. Good news, we're going to go on break. Bad news, I'm going to cut the break just a little bit shorter because we're running a little behind. So let's rejoin here at 10:22. We'll have a 7-minute break, and I'll see everyone back here at 10:22. Hello, board members. I'd like to welcome people back into the room for the July Oregon Health Policy Board meeting. Next on our agenda, we have the Affordability Committee's draft recommendations. So the chairs from that committee, Laura Johnson and Jennifer Menson Kennedy, join us this month to continue our review and discussions of the Affordability Committee's recommendations. So thank you so much for coming back, Laura, and welcome, Jennifer. And you two may begin when you're ready.
Thank you. So I'm going to do the first set of slides and then hand it over to Laura, and then we'll happy to answer both questions, any questions you guys may have, and thank you for having us. So we'll go to the next slide. So just as a reminder for individuals about our committee's charge was to develop and recommend cost reduction and cost growth reduction policies. Of course, a lot of hard decisions and lots of hard things to think through. And of course, to challenge the status quo, which has been a lot of great conversation on the committee. Next slide. Before we started all this work, we did talk about some guiding principles for the committee to help us as we were going through a lot of this. And you've seen these before, so and everyone has the slides, so we won't. And thank you for posting the draft recommendations in the chat. Next slide. So a recap was that Laura had come to you guys at the June meeting with some initial recommendations, and this committee had asked us to continue developing in more detail whether professional services should be included, whether there should be any exceptions, and any other specifics about the policy. Next slide. So we had a lot of great conversation, and we really framed our last meeting around further diving into the asks of this committee. Next slide. So with consultation of Baylor Health, the committee identified 6 key questions to help identify or to frame our recommendations a little bit further. And so these questions are informed by other states' efforts that we have been talking to. Next slide. So first, of course, was our initial draft recommendation was hospital price regulation, which limits the price hospitals can charge. Our update was that this committee had asked how RBP relates to in-network and out-of-network prices, and because hospitals would be accountable to reference-based pricing, the hospital's in and out-of-network status is a moot point, and it applies to all payers because the price itself is being regulated. And additionally, there is a ceiling, so hospitals could still negotiate lower in-network pricing with payers if they chose to do so. Next slide. So which hospital services should be subject to reference-based pricing? We had talked, this applies to all hospital and outpatient services. So the update is that professional services so this is a note, professional services include the clinical visit and treatment by physicians for care at the hospital. And this differs from the professional fees for outpatient services. So it might be advisable for OHA to give OHA the authority to include professional services in statute, even if it would not roll out monitoring of OP and IP caps and determine feasibility. So that's that. Next slide. Very good. Which hospital should be accountable? So is there a difference related to this? And of course, what are those exemptions for hardship? And we had a lot of conversation around this, and very specifically, we felt that there shouldn't be a blanket exemption, and that there should be a policy or process for when exemptions were given for hardships, and it should be very narrowly defined, must be proven by the entity, and must be time limited. And this isn't something that if a hospital said, hey, we had a really bad quarter, we would we would like to have an exemption. They do have to show kind of a long-term multi-year basis for financial distress, because organizations can have a bad quarter, had several bad quarters, but it's really about looking at the historical data of the organization. And the reference-based price cap should still apply 2 hospitals granted the exception. So the exception allows for a higher cap initially and then a lower cap to come into compliance. So we thought about really having a policy to have some flexibility, but not just a blanket exemption status given. And then next slide. There's no updates. This was a lot of conversation around this one too. And so there was no updates really for this one. The committee discussed data from OHA showing each hospital's paid amounts as a percent of Medicare for inpatient and outpatient services, along with other service categories, and didn't feel the need to change or deviate from what we had initially recommended on this one. And Laura will start with the next slide on slide 11.
Hello, everyone. So this slide is focused on how savings should be allocated. We did have a lot of discussion on this one. We did talk again about how balance billing would need to be part of this, where we would not allow that, to make sure that consumers would be protected from the hospitals billing them the difference between the reference price and whatever they would like to charge. And then we also had a long discussion, but didn't necessarily settle on anything in particular on how insurance premium rate review could factor in to this program, potentially requiring carriers to submit statements showing how they are reducing premiums, and then potentially requiring carriers to meet investment targets that would rebalance spending towards specific areas that are currently underspent, like primary care, for example. We can go to the next slide. And this is just sort of reviewing what we brought to you last time. So this is about mitigating against potential unintended consequences. So we can just sort of quickly review these, but in alignment with the committee's guiding principles, we should strive to mitigate, of course, against service reductions and hospital closures, forbid balance billing, as I mentioned, and then monitoring and reporting. And we discussed a phased-in option, and you'll see we talked a little more about that if you want to move to the next slide. So we again discussed a lot of these ideas, didn't necessarily land on consensus on each of them, but these are some of the things we talked about. Potentially imposing a price growth cap for prices below the reference price. So essentially, instead of everyone just immediately raising their prices to 200%, if they are below that, having a slower way to reach that 200%. So we also mentioned that we know we have a cost growth target program, and that we should be careful to make sure that everything sort of works together to avoid confusion. We also, again, talked about monitoring for any cost shifting. If we aren't, as we mentioned, the professional services part is quite challenging, but we are worried if we don't include it, we need to make sure we monitor whether, or not prices are getting shifted and costs are getting shifted between hospital services and professional services, especially when they're all owned by the same system, and also monitoring market power and its influence on prices. And then we did talk again about a little more about the phasing in. One option would be to start everyone at a higher percentage of Medicare, for example, 300%, and slowly reducing it down to the reference price of, let's say, 200% over the course of maybe a few years. Or we could start with some types of services, like the most common services, or those that are already the highest above the reference price we're suggesting, and then slowly move to expand to more service types. But again, we didn't necessarily fully get to agreement on any of these issues, but this was the conversation that we were able to have in our last meeting. Okay, we can go to the next slide. So this is a summary of overall where we've landed, I think. So basically, this is the key elements of what we're recommending. That all Oregon hospitals would be subject to a reference-based price cap for inpatient and outpatient, 200% of Medicare. Providers would be barred from raising prices up to the cap. Again, maybe we might allow for some slow movement toward that, but we would want to make sure we have a process for dealing with that. As Jennifer mentioned, we would have narrow exemptions that would be allowed for financially distressed hospitals, but we believe that no hospital should be fully exempted from the cap indefinitely, but maybe would have a longer runway to achieve it. And hospitals would be banned from balance billing. Go to the next slide if you would. And then we decided these are the things we would direct OHA to do as part of this, which would be to create a process for identifying those financially distressed hospitals based on, as we said, a multi-year financial analysis. We would establish benchmarks for services that, or the agency would establish benchmarks for services that don't have good existing Medicare benchmarks. We've talked about this before: pediatric, psychiatric, maternity care. And then establish a monitoring and enforcement program in collaboration with DCBS. So, as we mentioned, this is a really complicated but very important part of the program. And the goal would really be that patients at the end of the day are feeling the impact via lower costs, premiums, deductibles, or copays. So that leads us to the discussion, which I think is the next slide. I'll maybe turn this back over to Kirsten to lead the discussion portion here, but we're happy to answer any questions and continue the discussion. So thank you.
Great. Thank you, Jennifer. Thank you, Laura. And just to recap for the board, the trajectory of this work is that we're looking to the committee has really worked at finalizing a set of recommendations for reference-based price concept for OHPB. OHPB will consider, we should ask our questions, provide feedback today. We would be voting on this recommendation in August. So I think to the extent that board members have questions, really want to see development or committee discussion in another area, today is the day to raise it. So Dr. Hemmings, I see your hand. Go for it.
Yeah, thank you for the presentation. I'm just, in light of our previous presentation, I'm just wondering what impact that discussions that need to occur in terms of the fiscal year for 2027, the governor's budget and all of that. How does this, did this work incorporate those potential changes? Does it now need to be revised? I'm just kind of wondering how this fits into the overall budget discussions that we just had, if at all. I don't know.
I would say I think the great thing is we have a lot of crossover staff amongst our committees who are helping to kind of bridge those gaps. And I didn't hear the last presentation you just had, but I would defer to some of the staff who might be able to answer that better because of the crossover you've had between the two of them.
I think Eve, I see your hand up, but just to Dr. Hemming's question real quick, I think it'll be interesting. I think there's two elements of this. There's like the impact of what is happening in the overall healthcare industry, and then there's the impact of, when we talk about like, well, we need a robust enforcement process in order to make this work. What does that mean for an agency that is facing significant budget cuts? And that is a real question. I think it's a good one that you raised, Dr. Hemmings. And I think for better or worse, we know that times will be challenging ahead, but we don't know what forms they will take yet. And so I think that this is going to be pretty iterative, is what I would expect. Welcome OHA staff to offer their insight. Claire, I don't know if you want to opine on this.
I mean, I'm happy to just, I think, say two things. I think one, that the governor's office is leading on the options that were presented, and so we're able to support and provide that input about what the impact would be, and that's similar in the nature of the information that we've provided at the request of the Affordability Committee. What would the impact be on various programs. And so we can continue to support that and provide information so that the committees and the board are making informed decisions about what those impacts would be. And again, just want to make sure that I think the second point is noted that the committees and the board are kind of taking all of the information that you're hearing, especially about what the broader impacts will be to the healthcare system, into consideration as you're moving forward with recommendations and decisions, and ultimately votes on these recommendations for next month.
Great. Okay. I see Eve and then Tony and then Hayden. So Eve, go ahead.
Thanks, Jennifer and Laura. I know that we've had a chance to work together and talk about these things in other settings. I am curious about how professional fees would be handled for employed physicians versus contracted physicians, because many professional services and hospitals are contracted out. So would this then impact the groups who are contracting with hospitals to provide these services, or would hospitals who employ providers be disproportionately impacted and then be motivated to contract out those services? And how might that be an unintended consequence? So I'm curious about that piece. You don't have to answer it now. Just wanted to raise it as a point of consideration. And I know that certainly on the industry advisory committee, this is a controversial proposal. I think that you know that. We've talked about that. And I anticipate a lot of industry opposition to the proposal as crafted. One of the things that we talked about at the last meeting, I don't know if you had a chance to cover it in agenda setting, is that it would be more palatable if we could include some things that would help hospitals, like state contracting on costs of pharmaceuticals, equipment, supplies, implants, the types of things that are really impacting costs for hospitals. And if we could help to do some things to mitigate those costs, that might help with some of that level of opposition once we get to an actual legislative concept that's being debated. So would love just for us to think about crafting some of those other things, or is there anything else that we can do to help reduce that opposition? Certainly, I live in a community where our hospitals are in deep financial distress and have been for years. I appreciate your consideration around that. And then the other piece that's come up as a question is for critical access hospitals who are supposed to be reimbursed for their actual costs. How does this impact them if their actual costs are above the reference-based price?
Laura, do you want to answer a part of that related to the physician providers?
Yeah, sure. I mean, Eve, those are really great questions around the professional services. I think that this is probably why it seems like no other state has yet figured out how to do that. Which is sort of why we were like, well, if in an ideal world, this would be included, because I think without it, it could lead to some, cost shifting, and but I don't think anyone quite understands that because it's so incredibly complicated, and to your point, like what kind of unintended consequences could result from doing it without careful consideration of all of those levers. We kind of are reticent to recommend moving forward with that immediately, but kind of liked the idea that, in Vermont, they had the authority to do it, but they are taking a very long runway to figure out even how they would even begin to do that once they have finished implementing inpatient and outpatient. So just kind of a broader thought on that.
Yeah, and to your point with the other stuff, definitely, to adding. And so as we're having conversations about this in general, trying to come up with, some of the main points of what it would look like, knowing that someone will, also add in some of those fine points into, potential legislation that would be much more robust, incorporating our points and incorporating a lot of this conversation as well, and creating our own solution, that we weren't going to create the end all final, policy to put forward that says this is exactly what we want, but saying here are some of those pieces that are really important. This is really a kind of a group conversation and a group development. So.
Tony, go ahead.
Yeah, thank you, Jennifer. Thank you, Laura. Really appreciate the body of work that the committee is doing. This is really exciting work. I think zoning in a few of the elements that I'd like to see more defined, and I think you've hinted at this and said this is ongoing work. But again, to that question 6 on mitigating factors, and this being a broad scope of policy, the challenges that how it would be impactful in the context of what we're discussing here earlier, Medicaid cuts, and then one hospital differs than the next. And I think hearing some of the specificity of learning how that would be for our different types of hospitals and which ones in geographic regions, and particular things like critical access hospitals. Our prior PEB and OEB policy did have exclusions in this, and it seems that the recommendations of the committee are to not have those in there. But I think having some glide paths or some considerations with that information you're still to receive would be ideal. I think that there are some areas that we learned across the country. There's a great number of different approaches to this, whether that's in Indiana or what Montana did or Rhode Island from history over a decade, and perhaps some attention to utilizing something like Rhode Island, where the growth cap for maybe those higher at risk hospitals is something for the committee to take a look at that. 200%, it seems, compared to some of the other states, is what we've used in Oregon, but a little bit on the lower side. I think the interest here is just to reduce variance, right? And reduce the standard deviation, where some hospitals are charging 600% for one procedure, and try and bring that into a little bit more of a normal price. But I think it would be helpful for the board here to hear more of those specific interventions we might be able to do to create a glide path for support for this policy moving forward.
Thank you, Tony. Hayden, go ahead.
Yeah, thanks so much for this report out. To the point on critical access hospitals and potentially more vulnerable hospitals, Eve and Tony brought this up. My assumption here would be that those hospitals, while they're getting cost-based reimbursement on the public side, aren't getting it on the commercial side, and directionally probably are actually getting rates, especially the independent ones are getting rates below where we would set this cap. I think that's an empirical question that would have to be examined and refined in any potential legislation. So I would just recommend that dynamic is acknowledged and in any sort of report out, and any future legislation could consider it. On that point of how we relieve the more vulnerable hospitals, I would have much less heartburn on this if there is also some acknowledgement of ways in which the potential savings from capping prices could be used to increase Medicaid investment. And that is a way to structurally channel money towards the hospitals that are going to need it the most while drawing down federal matching funds. Would be happy to talk offline further about the mechanics of what that might look like. I know that the Affordability Committee is not going to engage a whole nother concept here, but in terms of voting for it and what the report looks like for recommendations, some acknowledgement of that potential to pair price caps with Medicaid investment to address this issue of standardizing payment across the system, trying to maximize federal drawdown money through Medicaid. I think that would be an important addition. I commend the group for leaving the option open on the professional fee side of things. And I would also suggest, if this has not already been considered, administered drugs, and whether that right now is being considered in price caps. And if not, I would recommend and hope that the report could at least include a reference to that. So the standard physician administered drugs, the average sales price markup that you see on the Part B side of things, that's another area that I think is a big pain point for payers right now, and one I think we should at the very least examine when thinking about overall price caps. And so that's all I got. Thanks so much.
Thank you. Bill, go ahead.
I want to again thank Jennifer and Laura for tremendous work on this, on tackling this tough issue and come up with a bold and I think well-developed proposal. Lots more to do on this, but represents a lot of progress and some very good thinking. I just wanted to reiterate for everyone the magnitude of the affordability crisis. Many of you have probably seen the proposed rates for the Oregon Health Insurance Marketplace. In the individual market, proposed price increases ranging from 11.7% to 25%, with an average request increase of 17.5%, and similar outrageously high increases in the small group market. Now, there are a number of reasons for that, but the bottom line is it makes the existing affordability crisis for folks in Oregon even worse. There's some excellent work, if you haven't, excellent reporting already, if you haven't seen today, by Bob Herman at STAT about this nationwide crisis, affordability, focusing first on small businesses. I had a couple of thoughts about possible additional steps for Oregon Health Authority. I appreciated that last slide about that. I think it would be helpful to have further work done on how and maybe when to include professional services. I am concerned about the dynamic that Eve identified and Laura reiterated. By excluding them, I understand it's complicated, but I think trying to at least develop a plan from perhaps including the authority to do that in whatever legislation might be developed would be helpful. I think also building again on Eve's suggestion, to develop some more detail on opportunities for state-sponsored purchasing of key elements that to reduce hospital input costs, I think would be helpful. I know some work's been done on that already, but fleshing it out further would be helpful. And then, of course, to begin to estimate the budget impact. And there may be both some indirect impacts on the state budget as well as potential administrative costs for oversight, enforcement, monitoring and enforcement of this program. So appreciate, again, the work that's been done. And I really hope we can continue to move this forward and flesh it out.
Thank you, Bill. Eve, go ahead.
The piece I forgot that has come up certainly repeatedly. If we can get some more information about what other states reference price caps are, but also does anyone else in those states have laws that mandate nurse staffing levels at the same level that Oregon does in terms of ratios and break coverage and that sort of thing, which is another piece that, all for good reason, has driven up cost in hospitals. And are we accounting for those differences in what's mandated into statute in terms of staffing levels within hospitals across states when we're comparing?
We can, and all of that's really good information for us to take and talk about, particularly at our next meeting on the 28th, and to be able to go through all of these comments and fold that in to the work that we're continuing to do. So. And then get a really good proposal back next time.
I'm keeping an eye out for additional board member hands. In the meantime, I'll share a few comments. Yeah, Eve, I don't know if it's possible for the industry advisory committee to actually flesh out some of the items that Bill was asking to be paired in terms of purchasing. But I think that actually might be a good body to identify the other side of that effort. That's possible. There was a slide about how savings should be allocated that I really appreciated, because I I do think attention should be paid to how rate review factors into this process and making sure that carriers are returning those savings to patients in the form of premiums or plan design. And then I also really appreciated the alternative, like kind of meeting those investment targets, or maybe this is a reinvestment or rebalance of spending into specific, very fruitful areas like primary care. I'm less enthusiastic about submitting a statement to carriers submitting a statement to show how they're reducing premiums. It feels kind of like a performative administrative burden to me versus actual change making. Uh, um, but I like the other two bullets. And I also just want to underscore this notion of thinking about what happens with prices are to the prices that are currently below 200%. I think that is very thoughtful and wise, especially after seeing PEB go through this process. Um, and so I appreciate that. And I do, I can't remember if it was maybe Hayden or Tony. I think maybe we do think about this adding to this concept, like a OHPB value statement almost around um, seeing OHPB seeing value in start moving towards equalized rate systems, so that like this is part of bringing commercial down. We think there's value in bringing Medicaid up, because not only is that important for providers, but it has an equity benefit in terms of patients and our society. So I just want to, I don't know, underscore that, say it, I really like that. And I also think this idea about having a runway to have thoughtful implementation might be very helpful to Dr. Hemming's very first point about like, how does this effort weave in and impacted by an impact on all of the other changes that will be happening in the next coming years, both within the agencies that will need to implement this and within the industry that is impacted by it. So perhaps that could help. Really appreciate the committee's work here. Really appreciate the collaboration between the Industry Advisory Committee and the Affordability Committee. So, that's it from me. Bess, I see your hand up.
Yeah, thanks. And I apologize if this has already been talked about in previous meetings as I'm just catching up here. But I'm curious if the reference-based pricing has any application to uninsured patient charges, given the number of people that are going to be heading off of Medicaid, and just thinking about that population growing and if there's any impact to that, or does it apply at all?
Laura, do you want to speak to that?
Sure. Yeah, I think it would definitely apply, because the way we're thinking of this is that hospitals can't charge more than 200% of Medicare. So regardless of who's paying, there will be savings for whether it's a commercial payer or it's an individual. That price can't be higher than 200% regardless of who's paying for it. So it should have some definite impacts there. Just while I have the mic, I would just like to say I totally agree with Kirsten and Eve to your point. I think if there are things that you feel would be beneficial to include that are, from the industry's perspective, that would be cost savings on the inputs side that could be paired with this, we would love to, consider that and put it together with this, I think. Well, I don't want to speak for the whole committee, but I would welcome that.
Great. Any last comments or questions for our committee guests? Well, then thank you. Oh, go ahead, Tony.
Oh, I just want to extend a great deal of thanks to just OHPB and to the Committee on Affordability in this collaborative effort and this discourse and this conversation to kind of help refine ongoing policy development. And as Bill, put up for us, we're really in the midst of an affordability crisis. And I think the board has taken an aggressive stance on this. And I'm excited to see that there is no perfect policy, but we need to move the ball forward. And I think that this is a strong effort at that. And I think we'll continue to work at that and move forward. So, and I just love the collaboration, just thinking about those different tabletops, the industry advisory committee. We've also been exploring with the primary care strategy group as far as, where delegating that work and getting the best expert analysis to bring forward so that we can elevate these ideas. And, as we mentioned, politically, these are challenging discussions, but hopefully providing the weight that is necessary to create some changes because people are really impacted right now. I was on a call last night and hearing about these, tremendous increases in the insurance premiums and what that equates to. And we just heard this really exhaustive list about Medicaid really being impacted in our state. And so just really excited to see us creating some positive direction. So just wanted to put that out there.
Thank you, Tony. Appreciate having that out there. Aaron, Peter, anything you'd like to add?
Nothing that I'd like to add.
Okay, thanks, Peter. Aaron, I'll keep an eye out for your hand. I don't want to miss it. Great. Okay. Well, then, next on our agenda, appreciate you joining us, Laura and Jennifer. And
Yeah,
thank you. Appreciation to the committee.
Thank you to all of you for your feedback. This is really, really helpful and appreciate the dialogue. So thanks again.
Yep. Thank you.
Okay. Next up on our agenda is the Primary Care Strategy Committee's draft legislative concept recommendations. So with us today, we have the chair and vice chair of that committee. They're going to present the draft legislative concept recommendations. So we welcome Rafaela and Betsy. Thank you so much for joining us. And you can begin whenever you're ready. Do we have Rafaela, Betsy with us?
This is Betsy.
Oh,
I am
there's
definitely
Betsy.
here.
Hi.
I'm not sure if Raf has been able to join us yet. So I'm being quiet to give her a minute to speak up.
I don't see them online just yet.
Okay. Well, I can kick off then. She is a doctor, and the doctor-y concerns, I'm sure, take precedence over today. So thanks everybody for having us here. I'm pleased to share the concept that we've been working through with the Primary Care Strategy Committee. And I'll just say out loud in case Raf joins at any moment, just speak up and interrupt me and take over. Next slide, please. We're going to start by, I just want to start off by going over a couple things about what the committee is up to and why it was created. Then we're going to talk about, Ralph just texted me, she needs the link. So she's going to get that and join us just momentarily. We're going to talk a little bit about how primary care is currently delivered and paid for, and then discuss our draft legislative concept, and then hopefully have plenty of time for questions and feedback. So let's start with the committee's charge. As you may recall, since this is the body that created the committee, we are charged with advising this body, the Oregon Health Policy Board, with strategies to stabilize, strengthen, and align Oregon's primary care system with the goal of increasing access to equitable, affordable, high-quality patient care. And if I didn't really introduce myself and what I do for my day work, but I am the executive director of the Oregon Academy of Family Physicians, and this is where I spend quite a bit of my time is talking to my members and hearing from them about the impacts that the current system is having on their patients and their ability to deliver great care. And so part of why this committee is exciting is that we're going to be able to take that holistic view and not just chase individual policy questions, but rather look at the whole system. In furtherance of that, looking at the whole system, we're trying to develop these actionable strategies that will pull together the threads of policy that the state already has in place that impact primary care, but maybe might have been developed in isolation or not in full context of how other pieces were developed. We have done a lot of work in the state of Oregon that the state and all of us as Oregonians should be very proud of to structure and really identify how to deliver team-based high quality care. We just have been poking at it and loading that model up with a lot of responsibility without the attendant payment that would make it sustainable to deliver. So that's part of what we're trying to focus on. We're also addressing, we will be looking at workforce. Probably most of you know, we don't have enough primary care clinicians in the state right now. Our wait times for new patient appointments are some of the highest in the country. And I can tell you from watching my membership rolls, the number of physicians who are reaching retirement age and retiring, in fact, is getting higher. And we're not replacing them on a one-for-one basis with new physicians. And that's just the physician side. We know that primary care clinicians in the state of Oregon also include nurse practitioners, physician associates, and naturopaths, naturopathic physicians. So we're trying to address all of that. Small charge. Ralph, are you with us? Okay, I know she's coming in. Not here yet, though. Okay, so let's talk a little bit about what we've been up to. So in April, can I have our next slide, please? Thanks. In April, we had our first meeting, went over our charge, established some group agreements and decision-making processes. In part because this committee was born out of the Primary Care Payment Reform Collaborative, we wanted to be really clear about how decision-making would work, and really clear that unanimous consensus is not necessary to make decisions and move forward, similar to the Affordability Committee, I think we heard. And at that first meeting, we heard from the OHA staff about some of the concepts contained in the legislative concept we're going to be talking through with you today. In May, we agreed on our vision and objectives, and we prioritized our strategies because there's lots of different ways you can try to shift or fix primary care, and we can't do them all at once. So we tried to go through a prioritization exercise to figure out where to start, and started our discussion on that legislative concept, which in June we decided on. So those recommendations are what I'll talk about with you today. We'll meet again next week on Thursday and discuss the feedback we received from all of you today to finalize those that legislative concept recommendation and incorporate any feedback. And at that time, we'll also have time on the agenda to start diving into some of the policy areas that we'll be looking at. So next week, we'll be hearing, I believe, from Deb Cohen, who is a professor in the Family Medicine Department at OHSU, who has done work at a national level, researching and assessing the costs and the ideal structure for team-based primary care. So we're going to learn a little bit about workforce and also sort of what do we mean when we say team-based primary care and how much does that cost. We'll continue that kind of work in August because we're understanding that not everyone in the on the committee comes with the same body of knowledge. And we're trying as chair and co-chair to figure out how to perhaps make space offline for folks to get some information on those kinds of topics as well. Excuse me, I'm just checking my text to see. Okay. And then in September, we're going to be developing some additional recommended actions based on the next set of our priorities. So September through December. So mostly what I want to call out here is while we're here to talk about a legislative concept that will be ready in time for the filing deadline for the 2027 legislative session. That doesn't mean this is the only policy idea that might find its way into legislation in 2027. This is a committee of folks who have a stake in primary care and an interest in primary care, as well as their representation of the best interests of Oregonians. And two of the folks on the committee are state senators, one of whom chairs the Senate Committee on Healthcare. And so if there are ideas that come up that could be addressed by a different legislative concept or something else a little further down the road, that is definitely possible. So I want the board to understand, as we talk about what's contained in this legislative concept, this isn't all we're going to do, not even all we're going to do this year. And so I think that's important context that I wanted to make sure you all had. Next slide. Okay. And then the next slide. So we're going to talk a little bit about the Patient-Centered Primary Care Home program. I'm curious how many of you have chapter and verse on this, but that illustration is really lovely because it shows all the pieces of what a medical home should look like, and it's shaped like a house. The idea of the medical home is rooted in some work published in the early aughts, I believe, that really talked about the 4 C's of primary care. So it should be the point of first contact. A medical home should be the first place an individual contacts when they're sick or they need care. It should be comprehensive. It should offer as broad a scope of primary care as possible. So hopefully avoiding unnecessary trips to urgent care or to emergency departments, and even handling some low-level chronic care that might otherwise be managed by a subspecialist. It should be continuous. So the ideal is that the patient and the clinic or the clinician would have a relationship over time, and it should be coordinated so that clinician and the medical home are kept informed about any other care that the patients receive in hospitals, emergency departments, or from subspecialists, and can help the patient make sense of all that care and how it all works together. Tony, I saw that your hand was up.
Just wanted to inform you, Dr. Betza is on now.
Oh, fantastic. So Ralph, are you set to go?
Yeah, sure, Betsy. Or
Yeah.
why don't you keep, you're doing such a great job. Why don't you keep doing this and I'll jump in on the next slide. How about that? I want to continue hearing your great thoughts.
Okay, sure. So the PCPCH program was founded or established in 2009. This was part of our bigger wave of reform that created the CCOs. The standards, so what does it take to be a PCPCH, a patient-centered primary care home? There are standards that clinics have to demonstrate that they meet. And those standards have been revised 5 times over the years, most recently in January 2025. There are technically 5 tiers, but only 3 currently in operation of all the primary care homes that we have in the state. More than 600 of them all are at the top 3, 4, and 5. 6 core attributes and 1 foundational attribute. I sort of talked about a couple of those, but the equitable care is really the most important foundational attribute. And what's important too is to understand that Medicaid carriers, the CCOs, are required to attribute their patients as much as possible to a patient-centered primary care home. But PCPCH clinics see all kinds of patients from Medicaid and from all kinds of commercial carriers. So changes that we make in Medicaid are happening to a subset of patients that a PCPCH might care for. So that's an important context as well. Ralph, do you want to take the next slide?
Sure, sounds great. And sorry I'm late. I am a full-time clinician, and so I just ran out of a patient room to get here. But yeah, I'm Rafaela Betza. I'm a family medicine doctor, and just briefly, I have been working in rural and frontier Oregon since 2016. First in John Day, and now here in Union County in Union and Elgin. And I'm excited to be a part of the Primary Care Strategy Committee, and excited to be chairing it because this is really what I live and breathe every day. And so, kind of just jumping right back in, to the PCH model, I think, this is something that over the course of my career, from starting residency in 2012 to now, is kind of where I've always lived. But, I came in at the start and I've seen it evolve over this time period. And, I can attest that the measures that we use to define PCPCHs in this program, they really do have a big impact on the day-to-day patient experience. And I would argue that they also have a very big and positive impact on the day-to-day provider experience, because providers want to work in systems where they are supported in providing whole person care. And so when we're talking about this program, I think it is important to remember that it's a program that focuses on process. But then this next slide kind of shows us that it also does produce outcomes, So, there has been research and studies done, and PCPCHs, they do lower the cost of care. So going to our next slide, this is just a study from 2023, but, it does show that, that patients who are enrolled in these medical homes, the cost of care is reduced by 6.3%, $76, per person per quarter. That's a big savings when you kind of put that across a bigger group of patients, 1.3 billion in savings. And then, this statistic we heard again and again, but I think it's important to come back to. So for every $1 in primary care expenditures, we're saving about $12 in other services. That includes emergency department care, inpatient care, and as Betsy alluded to, chronic conditions that can be managed in primary care should be managed in primary care, because it is cost effective. And then there's also the kind of the patient-centered outcomes. It improves patient access to care. So, 85% of us that work in a primary care, I still call it a medical home, sorry, but a PCPCH, we see that it improves patient access to care. It helps us improve care coordination, and it helps us improve equity. And so I think that, both from the financial standpoint, but from the patient experience standpoint, this program has been successful. And I'm a big believer that we need to also think about the experience of the healthcare providers when we're talking about improving healthcare. And I think that it has improved the experience of healthcare providers as well. It helps us provide the kind of care that we are trained to give and that we want to give our patients. So one of the medical home measures that we all have to attest to, right, is providing same day access. This is just like one example that I thought was cool because it's kind of on the ground. Providers want to say yes to same days. If our patient calls us and wants something, we want to say, absolutely, come in. I'm going to help you with this. Urgent care is great as a fail-safe. I'm an urgent care medical director. I'm not opposed to urgent care, but everybody deserves a primary care provider. And we all kind of want to see our provider who knows us the best when we're sick. And so having a clinic have to attest to a measure that we're providing same-day access makes it so that it's not up really to the individual provider to cram one more patient in order to provide that access. The whole clinic is working together to provide that access. That means that we protect appointments in the schedule. That means that we train our front desk staff on how to triage and determine who's appropriate for those slots. It takes a whole team to provide the kind of comprehensive care that we want to provide patients without burning out our providers. And so having a program that really encourages a whole clinic, a whole organization, everyone from the administrators in the back office to the front desk staff, to the medical assistants, to the nurses, and to the provider and to the patient, helping us all get over that finish line. That's really what I see this program being about. And that's really what I think the impact is on the ground. So from that on the ground experience, and there's many more examples than just that. I just thought that was like a nice illustrative example. So from the on the ground experience, this program is impactful, and it's impactful in a positive way. And so, moving on to our next slide. So team-based primary care is really kind of central to what the PCPCH program is all about. And this just means that, your healthcare isn't about just one person. It's not just about your provider. Like, yes, that relationship between a provider and a patient is really important and central to primary care. But there's so much else that can go, that there's so many different areas of expertise that can go into helping a patient stay healthy. And so we want to achieve a collaborative model where many healthcare professionals are working together. And the patient and the patient's caregivers are partners. They also have expertise. And so it's a partnership between all of these different people. And you really need to do a lot of coordinating to make that happen. The research demonstrates that this team-based care can improve utilization, which is important because we have a huge cost problem, of course, decrease healthcare costs, and improve outcomes, and improve, most importantly, I think, patient-centered outcomes. So, when your team is working together, you're less likely to have readmissions, you're less likely to have fragmented care. You can expand that access to care because you have less wait times. And yeah, importantly, it increases job satisfaction from your healthcare providers. So what this really means on the ground, again, like an illustrative example, is that over the years, as the model has developed and grown and more payment has been attached to the model and we're able to pay for this care, I have seen the incorporation of nurse case managers into my practice. That has been transformative, especially living in a rural area. A lot of times, if one of my patients needs to see a specialist, they need to travel, forget about to a different town. They need to go to a different state. We're in the far little northeast corner of Oregon here. Idaho is way closer to us than Portland. And when you get into, different healthcare providers in different states with different, electronic medical systems trying to all talk to each other and keep track of the patient's medical list, and they haven't heard back from this person, and has the referral been authorized by insurance, and yada, 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 you need kind of like an advocate or a case manager who has a lot of medical expertise to help you navigate that. And prior to this model, the healthcare system didn't really have a way to pay for that care, even though it's so important and really prevents patients getting lost in the shuffle, which is what leads to those extra admissions, extra ER visits, extra fragmentation. And so I've seen the incorporation of nurse case managers. It's been life-changing for patients and for me as a provider, because prior to having a nurse case manager, if you needed someone to kind of figure out all those bits and bobs, it was me as the primary care doctor. And that gives me more time to do the things that only I know how to do on the team. And so it's been great for patients and great for healthcare practitioners. I've seen the incorporation of clinical pharmacists into our teams. That's been another real game changer. Again, prior to having a little bit more payment support for this program in place, they can't really bill for their own services. They sort of can now, but not really. And so we didn't really have a mechanism to bring those team members on until this program became more and more developed. So I do think that kind of bringing it back to these real world examples of like, what are patients really getting out of this? And what is the healthcare team really getting out of this is important to understand that it's not just about process. It really is delivering outcomes for these concrete reasons. So team-based care is something that I think, always sounds good in theory and really is very good in practice. And so that brings us to our next slide, which is kind of building a primary care payment model. So, in the old days, I think before I was even practicing, right? Like we didn't have any of these programs. And so everything has always been traditionally fee for service. That means, like a healthcare provider sees a patient and they bill for that visit. If they do a surgery, they bill for that surgery. If they, and then they get paid for that particular service. And in theory, the fees are set so that you're just paying for what you're doing in that moment. So if a patient sees me, I charge for what I've done, but then that means that basically I'm responsible for everything, right? I have to be the pharmacist and I have to be the case manager because we're not paying for any of that other team-based care that the patient really needs to have the best outcome. And I think that all of you are probably better versed in the academic or theory side of this than I am even. But I think it does bear mentioning that, the traditional way that these fees for services have been set, for reasons that could be a whole, I'm sure, class in public health school, really do favor surgical care, specialty care, an inpatient care that is delivered in kind of expensive settings, like, legacy academic institutions in the Northeast, for example, and so that's kind of the system that we all inherited, and everything that we talk about in these meetings, whether it be, PCPCH, rural health clinics, value-based payments, performance measures, all of this work is trying to get to a place where we move away from that one model, in order to pay for this team-based care. And we need to do that because I think patients and government and society and providers ourselves are asking to move towards this model because it is better for patients and it is more cost effective. But in order for clinics to be able to move to that model, the work needs to be paid for. So, fee for service, that's like traditional old-fashioned payment models. And really, frankly, that's really where we live most of the time. And that's still where even primary care kind of lives most of the time. There's this, and so we want to connect all of this at any level that we can to value. So, on the one side of this chart, we have fee for service. And then so possible mechanisms to link payment to value in a pure fee for service model would be just paying for medical homes, right? We know that medical home care incurs some costs that are not covered by fee for service. So we can support that infrastructure by just simply paying for that infrastructure. So that's where something like a per member per month payment for a patient-centered, care home would come from. And the benefit of that would be that, we're putting more resources into what I think all believe are high value services. We've, gone over some evidence that these PCPCHs save money and that they improve patient outcomes. And, I think that, there's some debate over, well, are we just paying for process without really knowing what the outcome is? But we do know that there's improved outcome with this more team-based care. And so if we're kind of living in straight fee for service, kind of just straight paying for this model on top of the fee for service is one way to support that higher value care. Now, if your base payment methodology is also kind of like hybrid, so you've got some fee for service stuff happening, and then you've got some capitation happening, then you need to think about some other ways to support that as well. So I'm assuming everyone here kind of knows what capitation is, but capitation is basically when practices get paid per patient, and then they're asked to provide the care that that patient needs based on an amount of money that everyone agrees upon in advance based on a contract negotiation that it should cost, right? So you get paid to care for a population of patients rather than, each individual service you're giving the patient. People like the idea that there's some risk sharing in this model, that, primary care clinics would be kind of asked to take on some risk there, because if, the care that the patient receives exceeds the contracted amount, then the primary care clinic is going to face some income loss because of that. I don't think that the scope of this discussion is really trying to decide if we like capitation or not. But I mean, there are some downsides to that, right? Because then, if practices are already kind of struggling to pay for the care that they're providing patients, and then they're experiencing some of that risk, then that can just become a downward spiral for practices. And I think we especially see that in smaller independent practices that maybe they are not seeing enough of a volume of patients to hire coders to make sure that the patient's complexity is coded appropriately and those upfront patients are set appropriately. So, I mean, there are some downsides to that. But then with capitation, if you really want to make sure you're adding in the value, we get into a lot of performance-based payments on top of that. We can set some quality measures, and we can make those payments based on either bonuses or penalties or withholding. That's where some of the risk sharing comes in. I mean, another possible problem with that is that when it comes to specific quality measures, we struggle to define measures that really improve patient-centered outcomes. And we struggle to design measures that don't increase burden on practices. Even claims-based measures can create a lot of administrative burden on practices and individual providers, because it all boils down to what little code you put into the computer. And if the codes aren't going into the computer right on the beginning, it doesn't look right in the end. And a lot of work goes into reconciling that between, the beginning and the end. And then last, you've got this pure capitation model where none of what you're providing is fee for service. It's kind of, you see this sometimes in closed systems. Like I think Group Health in Seattle used to do some of this. I think Kaiser is able to do some of this, where you're really kind of just paying for a population and taking the fee for service out of it. And then it's just kind of more of the same. So you've got shared savings. If you're able to keep the cost of care down, the clinic gets to keep that savings, which hopefully is getting reinvested into improving that, all that quality of care, but also some shared risk. And there's always going to be some quality improvement, impacts and performance metrics to go with that as well. These are kind of the main ideas in the primary care payment ecosystem. These are the main things that have been tried both in Oregon and nationally. And these are the main kind of like conversation points that are out there when we're trying to talk about how do we get from pure fee for service to a model that really, prioritizes quality over quantity of care. And then kind of moving on to our last slide about our introduction. So, lots of states are looking at this and lots of people are looking at this. I think we all kind of know that we need to get somewhere different. It's just kind of, we don't have total agreement on how to get there. And so, there's some stuff that we can look at, so there's this primary care investment network. It's, it's where we get a lot of our ideas that we talk about in our meetings, 20 different states, working together, sharing ideas, sharing kind of pilot projects, sharing what has worked and what hasn't worked. And then there's this primary care policy menu for states that, again, these are all resources. Like, we are not inventing the wheel. We have not invented the wheel with these slides. We don't necessarily need to invent the wheel with the work that the Primary Care Strategy Committee is doing. But these are some of the resources that we use nationally to kind of keep abreast of what people are working on. So I'll pause there. So, and just open up for like questions or comments. Like if anyone wants to contribute, if anyone feels like we missed anything or anything, if anyone has anything to share, I'd love to hear it. We'll pause for that. I don't see, oh, Kristen, yeah?
No, I was just gonna say Hayden has his hands up.
Awesome. Thanks for that overview. I'll jump in quickly here, and then I think we'll probably have time to weigh in before. And I'm going to forgive me for being slight Debbie Downer, but I think it's important to raise a few points as we as the board think about what final proposal will come up. I think and I just want to raise a few here initially. I think we have to be careful on the assumptions on cost savings that we make on primary care investment. The study that was cited before, as much as I wish it to be true, very much departs with the broader literature here and on PCMHs as a mechanism of containing costs, which is different from the question of, as you raise, improving patient care, being better for providers, fulfilling this mission of the intrinsic value of primary care. I don't need to get into like the details. This was not a peer-reviewed study. It didn't have sort of diagnostic tests about whether there were selection effects, yada, yada. And happy to have that conversation separately. But it's one study that I think really, some of these saving estimates really depart from the broader literature here. And I would hate for us to get caught in a world where we are overpromising that investments in primary care are going to significantly address our cost problem. And this connects up to these other affordability issues we're talking about when we're thinking about other ways of addressing costs. Let me just leave it there, and I'll share further remarks when you're done.
Thank you. Yeah, thank you. And Kristen, were you trying to raise your hand to point to the other hand that was raised? Or?
Yeah, I was just helping facilitate, so you can ignore me.
Okay, thanks. And Eve?
Thanks so much. I think to Hayden's point, I believe Oregon's already near the top in terms of what percentage of our total healthcare expenditures are invested in primary care. I would be just curious to just get that comparison. Where are we? And then do we have evidence that the investment made so far has contributed to decreasing healthcare costs? And if not, what might need to happen? Because I believe all the things that you're saying. I run a primary care clinic or a set of primary care clinics, and we do have incredible ability at the primary care level to reduce overall healthcare costs. I just wonder if something maybe is getting in the way of the investment that we are making leading to those cost savings, and what we could do differently that would help to achieve that in a way that would really make sense to invest more, given where we are in comparison already to other states.
Yeah, thanks for both of those comments. And I'm just going to speak as someone who's in this discussion. I'm not kind of speaking for the PCSC or anything like that, but I don't think, from what I know of healthcare costs too, I don't know that primary care really is the main driver of our cost problem in healthcare overall. And in primary care, we often are in the position of trying to be all things to all people. It's hard for primary care to really drive a reduction in healthcare costs when a lot of the really high cost, low value care that happens in the healthcare system happens outside of primary care. And I think that one thing, I have talked about, just in my own organization, I work for Grand Run Hospital and Clinics, we're a critical access hospital and we run rural health clinics, is one of the things that really frightens us about capitation is that there's a lot of the healthcare spending that our patients encounter that we have absolutely no control over. I might think that someone needs to go see a specialist for a specific condition, but once they leave my office, whether the care that's offered in that specialist office is high value and cost effective or low value and not cost effective doesn't really have a lot to do with me. And so I do think that one thing that I think is important to say when we're talking about improving primary care quality and patient experience and provider experience is that for me, and granted I'm a workaday family doc, so my concern is making things better for patients and making things better for the healthcare system, is that I think the quality of care should be the main driver of these conversations. I think that primary care has the potential to help reduce costs, but expecting primary care to kind of be the entity that solves the cost problem in healthcare is probably not realistic and not something that we could accomplish. Betsy, did you have a hand up? I'm not sure if you had something that you wanted to point out as well.
Yeah, and I'll expand on this a little bit more when we get into the legislative concept. But I just quickly to possibly start to address Eve's question. Yes, Oregon, by our methodology, which is unique nationally, right? The way we calculate how our carriers are investing in primary care is different from national methodologies. And national reports that look at our primary care spend, specifically the Primary Care Collaborative, I believe, their most recent statewide, countrywide benchmark said that we were spending about 5 or 6% on primary care. And that's based on Medicare's claims, which is different from how Oregon is measuring. And that's okay. I mean, that doesn't mean they're wrong and we're right, or we're right and they're wrong. But I would just point out that among our carriers in the state of Oregon, we're ranging on the 2023 data from 17.1% spend down to 5.9% spend. So there's still really a lot of variation among the different payers, and that's material. I think there's lots of reasons that cost has not, the primary care isn't containing cost. I would also point out that in Massachusetts, they're finding on their 2024 set of data that they're working on right now, or excuse me, their report is already out for 2024. They're finding primary care spend is decreasing from 2023. And we're seeing that in Oregon's data as well. And that is more a function of the overall cost of care, overall spending increasing at such a sharp rate that it's very difficult to keep primary care spend at a sort of steady percentage. So that's part of what we're trying to address in the legislative concept that we'll be talking about. And maybe I should stop answering that question for now, and Raf can start on that part. Though, Kristen, if you have something you wanted to speak to.
No, that's actually what I wanted to speak to, is that we're kind of running close to the end of our meeting. We do need to have public comment at 11:50. So to the extent that, and we can have you all back, of course, because this is an important topic, but if you want to prioritize, because I think you had several discussion areas, encourage you to put forward what you most want.
Thank you. And I appreciate that. I could probably talk about this all day. So, but yeah, let's move on to what we came here to do. So, our next slide. So I'll just be very brief about this because I think we just need to jump right into the three concepts. But we just, so the PCSC committee is new. We're new in our work. And we had very limited time to think about and develop these concepts. These three ideas were presented to us by OHA staff who had already done a ton of work. And it's not just OHA staff came up with them in a vacuum, right? There's like a big process and many years of work going behind these three concepts. And I think that the overall, the feeling of the committee is that while we're advancing these ideas, we're really just getting started, and we're really excited to talk about kind of like bigger ideas and bigger solutions. But these are the three that we felt we were able to advance expeditiously. And I also just wanted to point out that our decision-making process is consensus-based. So, among some of these proposals, there might have been a little bit more or a little bit less disagreement behind the scenes, but nobody felt so strongly about disagreeing with any of them that they wanted to just block it. And so, consensus is consensus. So, just some things to bear in mind when we talk about these concepts. So first off, is a per member per month payment for patient-centered primary care homes. So, as we talked about, the problem is that, as we try to transition to this whole person team-based care, there are these demands. I mean, that kind of has a negative, these expectations or requests made of primary care providers and lack of sufficient funding to support the work that we're being asked to do. So a proposed solution is to require all payers in Oregon to pay a per member per month fee to PCPCHs in their network to sustain all of that team-based care that we just talked about. The payments would be tiered based on the tier status of the clinic. So if you're able to attest to the highest level, your payments would be higher. We would not legislate a recommended minimum or recommended amount due to, one, we think insufficient time to reach committee agreement on an amount, and two, we would run into some difficulties on the federal level because of Medicaid waivers and whatnot. And then, the other thing to keep in mind here is that OHA, that the CCOs for Oregon Medicaid already do this. So this is already happening in that space. And so this would be kind of expanded to all Oregon payers. I'll pause and go to the next slide. So current CCOs and public employee benefit plans already do this. Some commercial plans do already do this. This would simply be expanding the requirement to all payers. And keep in mind that under the current contracts, like sometimes these payments are low, right? Like sometimes they can be as low as like 40 cents per member per month. And sometimes the payments can be much higher than that and have a significant impact. Okay, discussion. I'm going real fast now. So discussion on this idea. Bill Kramer.
A question of clarification. When in terms of requiring all payers, does that apply just to state regulated payers?
That's right.
So it would not apply to ERISA plans. Is that right?
That's correct. Anybody Oregon can regulate would be required.
But that's a relatively small amount of the commercial market, correct?
Yes, although I believe that the current CCO contracts include this provision, but it's not legally required. So this would shore up that in case there are changes in coming contracts.
And then another thing we're looking for too is not necessarily questions for us personally today. And maybe these are things that could even be sent, by email offline, but questions that you want our committee to consider and discuss, or any aspects of the recommendation that you would like us to consider and discuss. We're looking for that kind of feedback that we can take back to our committee to discuss further and refine further. Yes. Hey, Hayden, I'm sorry. Am I saying your name right? Is it Hayden, or what would you like
That's
to?
perfect.
Perfect.
Yeah.
Okay, good.
Yeah. Thank you.
Thank you.
One quick thought here, and thanks for this first pillar. I think it might be worth considering how strict the committee wants to be on a PM payment versus some other way of paying the practice. I think this is sometimes where we see some slippage in how we're thinking about fee for service versus other types of payments. I very much agree that fee for service payment for primary care has been inadequate, but I think that's more a function of how much we have paid primary care than the mechanism by which we are paying it. And I think it's that resource amount that we really want to focus on here. As you mentioned, there's some downsides to capitation. It implicates all sorts of questions about risk and attribution. I think the focus, at least the committee might consider the focus here being just ensuring that the payments are made to primary care and less focused on the type of payment. As you mentioned, if a PCMH or an FQHC or any sort of practice has team-based care, if they're getting, for example, double the amount per visit, that of course is going to, even in a fee-for-service world, that of course is going to facilitate, enable more of that team-based care. So just a note of caution or reservation from my perspective on dictating the type of increased primary care payment.
Thanks for that. We'll definitely write that down and take that forward. Bill, and is Bill okay? Is that okay?
Yep.
Bill?
Yep. Just a slight addendum to what Hayden said. I actually do think the structure of the payment is important. And one thing, I think you said this, I'm not sure it's on the slide, that it not only should provide additional amount, but that it gives more flexibility in how that payment is used by the team. So I think that's an important thing that is accomplished through the structure of a PM payment for primary care.
Perfect. Anything before we move on? And I'm assuming we can absolutely take, as thoughts come up, emails, that we can take back to the committee is perfectly fine. So, okay, perfect, good. Okay.
Okay.
Pass it on to Betsy. Yeah.
Yeah. The second pillar of the legislative concept, and I'm going to go really, really fast, even though this is a complex concept. So please bear with me, and feel free to follow up with thoughts offline by email or whatever else. Right now, Ralph went over a little bit of the sort of general characteristics of what value-based payment looks like. In certain kinds of value-based payment contracts, clinics are rewarded for performance after the year is done. So if in 2025 they had to get 85% of their women who should be having a mammogram to get a mammogram, and they do, they won't see actually the reward for that or the full payment for that until 2026. And that's a problem in that it takes staff and money to get all those women in for their mammograms, and clinics are often strapped to float the expense of achieving the work of these quality metrics without full payment for those quality metrics. And so, and mammography is a really good example because a primary care clinic doesn't get paid for a mammogram. People get their mammograms elsewhere. So, but they're held accountable if their patients aren't getting that screening. So this chunk of this legislative concept aims to create the option for payers to potentially offer more of that money, more of that sort of reward money, which we know from practice is not actually a reward, but in fact a functional payment that helps support the work up front, and some portion of that reward money at the end of after the performance year. This is not an easy this has some nuance. Not all clinics might want that because the risk may be that if they take the money up front, they don't hit that target, say they only get 84% of their people in for mammograms, they might have to give some money back. So we hesitate to require that clinics accept this, but we do want to make sure that ensures that Oregon can regulate again within that pool, including CCOs and the individual and small group carriers offer it. And that is an acknowledgement that as we shift to value-based payment contracts, as we are trying to, that's been state policy. The unevenness in those contracts, the lack of alignment in those contracts can make the financial risk to clinics really intimidating because they are not, many, especially independent and small clinics, are not super sophisticated, do not have super advanced data analyses capabilities to be able to say, yes, that's a good deal. I think we will be able to get 85% of our people in. So yes, let's take that risk. So I'm going to pause there and see if there are questions. We note here that at least 50% of what a practice is eligible for should, for now, this is drafted such that it would be 50%. That's exactly the sort of detail it might change through your feedback, through the negotiation process, and getting this legislative concept forward. Any questions on it? Hi, Hayden.
One more quick thought. My apologies for so many comments here. I figured it's better to get them out now. I would really implore the committee to scrutinize the value of these quality metrics and the land framework. Again, the empirical literature on this for the last 20 years is very, very poor. And the downside is imposing more burden, administrative burden on our CCOs and our payers and on our practices. And so, and I know through various incentives, the state it has programs pushing, but I believe this was suspended in the last year for CCOs, pushing towards the land, on the land framework, and also pushing P4P quality metrics. I think now would be a great time to reassess whether that is a good strategy for the state and whether we want to lead in departing from that and moving towards simplified payment that reduces this sort of burden here. So I just wanted to just get that out there as the committee thinks about these.
You're speaking like an advocate, and yes, absolutely. Do we need fewer measures? We 100% do. Is there legitimate conversation to be had on the whole experiment of the enterprise of measurement? I believe that there is. Having said that, that is a gigantic shift from where we are right now, and I think that we can both seize the opportunity to look at that gigantic shift while we try to make things a little better in the short term. And that's sort of how I think about this legislative concept. That this is an attempt to set a direction, set a course, and try to bring some relief to primary care clinics as quickly as we can because they are suffering right now. Access is compromised by the complexity of how this stuff is working right now. So I totally take your point, and I do hope we're going to get there too. Tony?
And I would just say we could.
I just want to do a quick time check.
Yeah.
We can add 5 minutes onto this piece, but at 11:55 we'll need to move.
And just on that point, Betsy, and thanks so much for it. Maybe one consideration here is not to reduce the payments, but think about whether it ought to be tied to quality metrics. Frankly, if any, would be my suggestion here.
Yeah.
Very brief. I echo all the sentiments that Hayden just mentioned, and I think we need to clarify really what is the value in value-based care with regard for pay for performance, and look further at the literature. And I anticipate the primary care strategy group will dive further in that as we see many states moving in this direction to constrict and really define what is actually the measures we need to hold ourselves accountable and for that payment. So
yeah. It's my personal opinion that the only measures that matter are access and comprehensiveness. Like anything that points to whether or not people can actually get in the door to get the care that they need, that's where we need to be. That's where we need to be focusing. But
I just want to get in there really quick. I preface this by saying that I haven't figured out on Zoom where the hand up button is, which is why I'm being rude and interrupting. But when I say that the Primary Care Strategy Committee is looking forward to talking about big, bold solutions, this is kind of exactly what I mean, Hayden, is kind of getting into the weeds of this exact discussion. And so expect more from us on this. And you can probably tell from all my enthusiastic nodding that I totally agree.
Eve.
I think there's a good kind of nexus and connection here with the Industry Advisory Committee
Yes.
we're talking about. So let's just make sure we stay in contact so we're not duplicating efforts and we're really coordinated. And I think this is the pathway to go down, because I just don't see a whole lot of proposals that are going to increase costs being successful this year. So the more that we can focus on reducing costs to primary care providers so that the payments received go farther to support primary care providers, I think that will have more legs as we get into session. So appreciate that.
Thanks, Eve. I appreciate that too. Appreciate your comment. Next slide, and let's see if I can sprint through changes to the primary care spending report. Next slide. And one more. Thanks. Okay, so Oregon has been measuring primary care spend for over a decade now. And while we were nation leading in rolling that enterprise out, many states have come behind us and been iterative, started with our approach and made changes and pushed forward and further into having more valuable data. What this piece of the legislative concept would do is remove the specific language that defines what primary care is from the statutory language. So it just pulls it out of statute so that it can be defined in rule through a multi-stakeholder rulemaking process. What that would do is give us flexibility as care changes over time. It would give us another opportunity to look at the consensus of how other states and national groups are defining primary care now as opposed to how it was defined before. And the other pieces of this would be to, right now, I mentioned before that our primary care spend at 12% is great. And why hasn't it worked? Well, we don't include pharmaceuticals in our definition of what healthcare costs are. There's a lot of complexity to why we don't do that and what the consequences would be if we did, given that the cost of pharmaceuticals is increasing so rapidly. Having said that, if that's about 20% of the spend and we're only getting 12% of what's left, that's not 12%. So I think this piece of this legislative concept is an opportunity to take a fresh look at that in the current context. And also importantly, which shifts the report deadline from February to September 30th, because it is not literally possible to get the data that we currently require per the statute, and for the OHA analyst staff to do the work they need to do to produce the report on that in that time frame. So that's a very high level look at what we would do there. I think there may be this will certainly be a rich conversation, and I invite any of you who are interested in it to join us as we dig into what that might look like should this legislation pass, and we hope it does.
Betsy, really appreciate you and Rafael. That's going through this so quickly towards the end here. I think our public commenter that we were slated to hear from is not quite online. Maybe sometimes people sign up and don't come. So I'm keeping an eye on that. Oh, G's here. Okay, great. Then let's wrap. We'll give you a couple moments to wrap up and then we'll move to public comment. Sorry, can this timer come off the screen?
If I could just offer thanks for giving us the chance to talk about this with you. Again, welcome any kind of conversation you might have. Particularly would be great if anyone has any thoughts they didn't get to express, if you could get them to Raf or me before next Thursday so that we can digest them for our next committee meeting. We'd appreciate that. Raf, anything else you want to say? All right. Thanks, everybody.
Thank you. Okay, so just to repeat that invitation, comments that we were not able to express here in the meeting, we should get them to the committee members before Thursday when they will have their next meeting to deliberate before the kind of legislative deadline for the upcoming session. But also, Rafael and Betsy, if you want to coordinate with liaison Tony, if when we come back to discuss and give you more time for what was obviously there's a lot of interest and robust discussion. So thank you so much. And with that, we will transition to public comment next. I need to read the little bit. So the Oregon Health Policy Board welcomes and deeply appreciates public testimony. It's one of the most powerful ways we demonstrate our commitment to profound listening and learning. So deep listening means that we will not respond to what you shared, nor will we attempt to fix or resolve the question or concern that you bring today. We will also not interject to correct inaccurate comments that are shared as fact. We will, however, bring it fully into our awareness, understand it as an important consideration for our work, listen with careful attention, respect, and honor that you deserve. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from that individual. It's not a representation of the Oregon Health Policy Board, its members, or the Oregon Health Authority. Each presenter is given 2 minutes to share, and in the event that that doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. And to keep this on time, we'll share a 2-minute timer for each commenter, and we kindly ask that commenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by board chairs and staff to determine appropriate next steps. So with that, welcome Allison Nesberg, and you may begin when you're ready.
Okay, sorry, was trying to figure out how to unmute. Can you guys hear me okay? Okay. So my name is Allison, and I am a registered nurse caring for patients with epilepsy and other serious neurological disorders. And I am here today because the current prior authorization and appeals process has become a barrier to medically necessary care for organ Medicaid patients. Many of the denials that we receive for seizure medications state that a formulary alternative is just as good or that the requested medication is not the least costly option. But epilepsy treatment is not one size fits all. Every medication decision is based on a careful review of patient's diagnosis, previous medication failures, side effects, and other medical conditions, and the best available clinical evidence. The least expensive medication is not always the safest or the most effective. Equally concerning is Care Oregon's current appeal process. Since 2025, prescribers can no longer request reconsideration after a denial. Instead, patients must initiate the appeal themselves or complete additional paperwork before we can appeal on their behalf. For many Medicaid patients, this creates another obstacle. Our patients may be experiencing uncontrolled seizures, cognitive impairment, developmental disabilities, mental illness, language barriers, or simply just having difficulty with navigating an already complicated healthcare system. And we have had appeals dismissed, not because the medication wasn't medically necessary, but because the required paperwork wasn't completed first. These delays have real consequences. Every day without appropriate treatment increases the risk of breakthrough seizures, emergency department visits, hospitalization, injury, and even sudden death from epilepsy. I respectfully ask the board to improve transparency by requiring public reporting of prior authorization denials and appeals and examine policies that prevent providers from initiating on behalf of vulnerable patients. Thank you for your time.
And thank you, Allison, for your time and comments. Also flag that there are written comments from Allison if people ingest better that way as well. So I'd like to thank all the attendees, board members, and participants in today's board meeting. Appreciate everybody rolling with it. Our next meeting will also be on Zoom. It'll be on Tuesday, August 4th at 8:30 a.m. Thank you, everyone. Meeting is adjourned.